It's been wrapped over here. So if your number comes out, you get that gift. So that will be at the end of every session. I'd like to request Vishali ma'am to do the honors of taking out one.
How do we know the number? There is no number here.
Will you come?
सब में एक ही नंबर अरे सब में एक ही नंबर
नाम लिखाओ डॉक्टर अरशद इकबाल is here. Okay, we'll come back. Thank you. That was the session. Can I have the lamp, sir? Lamp. So, good morning everyone. On behalf of Bihar Ophthalmological Society, we welcome you to the 17th midterm conference. It's really an honor. We had a brilliant, inquisitive kind of session by Dr. Vishali ma'am on this very thoughtful topic, which really incited many questions inside us. To start with the inaugural program, may I request our chief guest, Dr. Syamanandan San Narayan Prasad sir, President IAB Bihar, please take the chair. Please welcome him with a round of applause. I request senior most ophthalmologist of this region, patron of local organizing team, Dr. Devendra Prasad sir, to please come on the dais. I request President Bihar Ophthalmological Society, Dr. K.S. Gupta sir, please take up his chair. I request Chairman Organizing Committee LOC, Dr. Arvind Kumar Sinha sir, please take the chair. I request Dr. Professor Nilesh Mohan, Honorary Treasurer of Bihar Ophthalmological Society, to take the chair. Request Dr. Satyajit Sinha, Omnipresent Chairman Scientific Committee, to take this chair. I also request Dr. Ajay Kumar to take the chair. He is the organizing secretary of this conference. I also request editor of Bihar Journal of Ophthalmology, Dr. Aranjana Kumar, to please take the chair. Now I request two postgraduate Rajesh and Ram to present the bouquet to our chief guest, Dr. Shyam Narayan Prasad. I request Ram to present bouquet to our patron, LOC, Dr. Devendra Prasad. I request for presentation of bouquet to President of Bihar Ophthalmological Society, Dr. K.S. Gupta. I request for presentation of bouquet to Chairman Organizing Committee, Dr. Arvind Kumar Sinha, ex-President of Bihar Ophthalmological Society, and now we can say that he has organized many very successful conferences at RAJGIR, so we'll be coming again and again to this place. I request for presentation of bouquet to Honorary Treasurer Bihar Ophthalmological Society, Dr. Nilesh Mohan. I request for presentation of bouquet to Chairman Scientific Committee, Dr. Satyajit Sinha. Request for presentation of bouquet to Organizing Secretary, LOC, Dr. Ajay Kumar, who is a very lion person, a very good organizer. First time he has driving. Now onward, there will be active contribution from your side, always. I request for presentation of bouquet to Editor BGO, Dr. Aranjana Kumar. Land lighting will take a little later, so I request to give the welcome address. Dr. Arvind, sir, please give your welcome address.
Can I request Dr. Ajay to please give a welcome bouquet to Dr. Professor Vibhuti Prasad Sinha, our secretary.
Thank you. Welcome to all the boss, executive president, secretary, and all executives, my guests and our colleagues, representatives, present here. I am very much delighted to see this gathering, and in the pre-conference evening, I think it was great, and it was great only due to your presence, and I assure you whenever Nalanda Thurkal will get opportunity to organize this type of conferences, we are very much organized here in a small town, Bihar, but our unity was very strongly, so I assure you for the future, whenever you will give us opportunity, I will fulfill strongly. Thank you.
Thank you, Arvind sir. And now I request President Bihar Ophthalmological Society to say a few words.
मंच पर उपस्थित हमारे मुख्य अतिथि बिहार के IIMA के अध्यक्ष डॉक्टर श्याम नारायण प्रसाद, हमारे डॉक्टर देवेंद्र प्रसाद जी, डॉक्टर अजय कुमार, डॉक्टर रंजना कुमार, डॉक्टर जी, डॉक्टर दिनेश और हमारे अरविंद कुमार जी यहाँ के ऑर्गेनाइजर, सभी को मेरा नमस्कार। आज के सेशन में जो इस मिड-टर्म कॉन्फ्रेंस का थीम रखा गया है, कॉर्निया और कैटरेक्ट, यूकैटिस एंड कैटरेक्ट, इसमें जो डेलिब्रेशंस हुए हैं उससे हम लोगों ने अपने डे टू डे क्लिनिकल प्रैक्टिस में बहुत सारे नई बातें सीखी और आज दिन भर के डेलिब्रेशंस में और भी सीखेंगे, ऐसी मेरी उम्मीद है। और हमारे ऑर्गेनाइजर डॉक्टर अरविंद कुमार सिन्हा ने इस मिड टर्म कॉन्फ्रेंस को अपने इनोवेटिव आइडिया से बहुत विशेष बना दिया है। इन्होंने मेहनत करके एक फैमिली गेट टुगेदर कल करवाया, जिसमें लोग राजगीर जैसे रमणीक स्थल का भ्रमण भी किए और शाम को पार्श्व गायिका के संगीत का भी हम लोग आनंद लिए। डॉक्टर मैथिली ठाकुर के गीतों का भी आनंद, और इन्होंने इस कॉन्फ्रेंस को एक विशेष आयाम दिया। इसके लिए मैं डॉक्टर अरविंद कुमार और डॉक्टर अजय कुमार और यहाँ के लोकल ऑर्गेनाइजिंग टीम को बहुत बहुत बधाई, बहुत बहुत शाबाशी देता हूँ। और इतना कहकर मैं अपनी बात समाप्त करता हूँ। थैंक यू।
Next, I request Editor Bijo for release of the journal by all the dignitaries on the dais. She has worked hard to get the journal under one publishing head, and now journal is on path of getting this indexing also. But before that, just we can have that title. So may I request everyone to please come forward to have the land title.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। वक्रतुण्ड महाकाय।
Now I request Dr. Rajna Kumar to get her journal released by dignitaries of the dais. And I'll request Dr. Rajna to say a few words.
Thank you, Dr. Vibhuti. It's been an entire tireless effort to bring our journal under the Walter's Kluwer banner, and an attempt is being made by us by an entire editorial team to publish quality articles and review articles and case series into this. And from this podium, I wish to request all the delegates who are present here or who are academically inclined and who are part of this academic extravaganza because of the interest into academics, they are here to contribute and bring up the quality so that we can have a greater impact into the academic arena as a journal of Bihar Ophthalmological Society. We are renamed as iQuest now. Earlier we were named as Bihar Journal of Ophthalmology, and now we are into iQuest. This is our second issue that is being published with Walter's Kluwer. Thank you.
May I request Dr. Vaishali Gupta and Dr. Manisha to join for the journal release ceremony. Please come.
जाओ जाओ जल्दी सर थोड़ा सा साइड हो जाए। हाँ बस ठीक।
A big round of applause for hard work of Dr. Rajna. Thank you, everyone. Now I request Dr. Satyajit Sinha, Chairman Scientific Committee, to do the honor of presentation of orations and award.
Thank you, Professor Vibhuti. Respected Chief Guest for today, Dr. Shyamnarayan Prasad sir, who is the President of IMA, Dr. Devendra Prasad sir, Senior Most Ophthalmologist over here, President Dr. K.S. Gupta sir, Dr. Arvind Sinha sir, Dr. Vibhuti, Dr. Nilesh, Dr. Ajay, Dr. Ranjana. It's a very, very happy day for me, and I say that from the bottom of my heart. Just a while ago, at the rear, I was telling everybody to maintain as much silence as possible. And maybe in so many conferences in the past 20 years, nobody has ever seen me going behind and telling everybody to please maintain silence in so many conferences. But I am so honored and so deeply humbled and touched by our orator for today, Professor Vishali Gupta, who gave her kind consent to come and deliver this lecture. You will not believe that 2 years back, we requested her to do the oration in Bihar, but she is so busy. Every weekend she is in one part of the world, leave alone India. She is one of the top 50 most recognized UBID experts in the world, which is a huge honor for our country. And it's a huge honor for us that she accepted our invitation to come to RAJGIR, to Bihar Ophthalmic Society. It was not easy. Generally, the top speakers, they just want to go from airport to airport, but ma'am traveled from Chandigarh to Patna and then from Patna to RAJGIR, and now on our way back she'll be going to Patna, then taking a flight to Delhi, then changing and then going to Chandigarh. And we are very, very grateful to you, ma'am, for this from the bottom of our heart. Thank you so much. It's customary before the award to introduce her, so I'll just say a few lines. Sir has already introduced her. She is a very accomplished vitreoretinal uvea expert of international repute. She is currently the secretary of the International Uveitis Society Group and the president of the Uveitic Society of India. She has received several awards and also holds US patent for multiplex PCR. I would now like to request our president, Dr. K.S. Gupta sir, and our chief guest to please join in honoring her with the Professor RHP Fina oration class. And I'd like to request ma'am to please come on the stage. Can I request Vaishali ma'am to please say 2 words on this?
Firstly, I must say my sincere apologies to Dr. Satyajit and all the people of Bihar for not being able to accept the invitation here. It is a beautiful, beautiful state, and the people are so full of warmth and love for life. I guess you guys celebrated till 4 a.m. So that indicates how much love and the joy and the celebration of life is there. And yesterday in one go, we saw birthplace of Guru Gobind Singh, birthplace of Mahavir Jain, not birthplace, we could not go to Gaya, but we know he's born very nearby. And of course the amazing Nalanda University. What a strong heritage to be proud of. And I'm sure with all of you there, you will take it to the same heights where Nalanda University was, so that the learners can travel for 17 years. He's just talking from Chandigarh, a flight. But I think Bihar has the capability where people would travel, you know. He traveled for 17 years to come to Nalanda, but maybe people will travel at least 17 hours to come here. And bring it back to its original glory, which was there many, many years ago. Thank you very much. I'm truly, truly honored and humbled to be here. Thank you.
Thank you, ma'am. One person in particular I am deeply grateful to, and who is the architect of, almost the biggest architect of this today's conference, is Dr. Manisha Agarwal. She has come all the way from Delhi, and she has helped me in making this scientific program, because we were making a program on uveitis. And Dr. Vaishali ma'am, Dr. Manisha, they are all top leaders of uveitis, and we wanted to get the very best to Bihar. All the speakers who are presenting are top notch, and all this has been made possible by Dr. Manisha Agarwal, who has coordinated. Other than that, she is our guest faculty today. I am very, very grateful to you, Dr. Manisha, for all the help that you have given. Without you, this wouldn't have been possible. And we would like to honor you and request you to please come on the stage. And I'd like to request our chief guest and Dr. Devendra sir and our president, Dr. K.S. Gupta sir, to please honor Dr. Manisha Agarwal. I'd like to request Dr. Manisha to please say 2 words.
So a very good morning to all of you, and at the outset I think I would like to thank Dr. Satyajit Sinha and Bihar Ophthalmic Society for inviting me and Dr. Vaishali. It's always a pleasure to visit this part of the country. And I remember having visited Bodh Gaya when we had attended the BRSP meeting, and now coming to another part of the state. I and Dr. Vaishali, we visited Nalanda yesterday, we went to the Gurudwara, and all the hospitality that we have received from the entire local ophthalmic society members. It's good to see that the society is now growing into an academic forum, having a lot of discussions, having very good speakers, and also having now a journal added to the society, which speaks volumes that how the interest into academics is growing, and that's something very encouraging to see. So thank you once again.
Thank you, Dr. Manisha. Just for your information, this journal has been there for many, many years now, but Dr. Ranjana has taken it to the next level. 47 years we have been having this journal, but now Dr. Ranjana has taken it to a totally different level. Thanks to you, Dr. Ranjana. Thank you, Dr. Vibhuti, and thank you for your time. Thank you very much.
Now I request President Sir to please felicitate our chief guest, Dr. Syam Narayan Prasad, President of IMA Bihar. Now I request Chief Guest, Honorable Chief Guest, Dr. Syam Narayan Prasad, who is President of Indian Medical Association Bihar branch, to come on the dais and speak a few words.
First of all, thank you everybody for choosing me as a chief guest. This is a meeting of ophthalmologists, not a physician. I'm a consultant physician and dermatologist. But I can see that you are the privileged person by seeing a simple eye of a person, he or she, you see the mind and the body. I repeat, I can tell the mind of that person as well as the physical element of that person. Be it retinopathy, be it uveitis, be it... I was listening to very powerful lecture. Really decent, not decent, a very powerful lecture. And two questions were thrown to us as physicians. Person suffering from uveitis, yes, 9 out of 10, they get heavy dose of steroid. And ultimately when they ran to our clinic, we blame the ophthalmologist. This is a routine affair. Oh, this much of steroid, you are going to be killed, to osteoporosis, to diabetes and whatnot, A to Z. But one question was also left to the thrown open regarding tuberculosis uveitis. Well, tuberculosis is our disease of India. This has been bread and butter of probably every faculty of medicine. But here is, I'm sorry to say, still I don't know why people rely on Mantoux test and TB board. Both are practically obsolete tests. A person having or on any immunosuppressant drug or for the steroid, simple steroid, you go for Mantoux test, it will be negative. So what do you do? A person who had tuberculosis earlier, or a physician like me, seeing thousands of tuberculosis patients in the last 10-20 years. I've been practicing for like 35 years. So if I get my Mantoux test done, it is bound to be positive. But it is 100%, I'm 100% sure I don't suffer from tuberculosis. So Mantoux test and TB board, these are the two tests cannot be relied on. Ma'am, you rightly said, your clinical acumen, your judgment is the final. If you say this is tuberculosis uveitis, I have to follow it. There is no controversy over there. So, when I was told that I have to be a chief guest of such an august gathering, a physician by profession. Well, I am president of IMA Bihar, that is not my job. Yesterday also I could attend this because we had to start our prestigious journal, Patna Journal of Medicine. But what I feel, and yesterday's the first journal after 10 years gap, Patna Journal of Medicine, but exclusively dedicated to plastic surgery and heart. Probably the next talk thereafter, it will be exclusive for ophthalmology. So this is what we are. Every journal, every issue will be dedicated to one particular branch, be it ortho, be it cardiology, be it diabetes, because diabetes is very dear to me. And what I see generally whenever I talk to in some meetings about diabetes, but diabetes is one disease, like tuberculosis is one disease which can affect only except the hairs are spared. So it can affect tuberculosis, can affect every part of the body. And so is diabetes. So tuberculosis is waning off. Hopefully, in another 10 years or so, tuberculosis will be a thing of past. but not diabetes. India is a diabetic country. And I have to take help of you people in my day-to-day practice to see retinopathy and manage it. When you diagnose it as retinopathy, I'm pretty sure that this person is suffering from nephropathy. A nephropathy patient cannot develop retinopathy per se, but a retinopathy, if he or she has developed retinopathy, he has to have some sort of nephropathy. So this is a mixed up type of thing, and I love that. आप लोग सब आँख के डॉक्टर हो, आँख देख के बताते हो कि इस आदमी का मूड कैसा है, ये आदमी कैसा है, गुस्से में है, प्यारा सा है, सोच में है, चिंतित है, और अंदर जब झांकते हो तो फिर बीमारियां ही बीमारी दिखाते हो, हमको बताते हो, अगर हमने मिस किया है तो ट्यूबरकुलोसिस बताते हो, डायबिटीज बताते हो, कोलेजन डिजीज बताते हो, सार्कोडोमा बताते हो, बहुत सा चीज बताते हो. Thank you very much. You have invited me. Thank you.
Thank you, sir, for enlightening us with your wisdom. Now I request Judge, Organizing Secretary of this program, LOC, Dr. RAJGIR, to say Dhanyavad.
Good morning, friends. शायद थोड़ा सा लेट चल रहे हैं हम लोग, जहाँ से मैं नहीं लूँगा. आज का कार्यक्रम जो इनॉग्रेशन सेशन था वो संपूर्ण हुआ. मैं सभी हमारे बॉस के जो एग्जीक्यूटिव मेंबर्स हैं उनको धन्यवाद, और चेयरमैन साइंटिफिक कमेटी उनको धन्यवाद, और वैशाली मैम को और मनीषा मैम को बहुत बहुत धन्यवाद. हमारे आईबीएम प्रेसिडेंट जो समय निकाल करके हमारे पास आए हैं उनको बहुत बहुत धन्यवाद, और सभी जो हमारे गेस्ट एंड स्पीकर्स थे आज के सेशन के उनको धन्यवाद. और मेन जो हमारे मेंबर्स हुए, जो हमारे बॉस के मेंबर्स हैं, उनको इतने नंबर्स में देख करके बहुत खुशी हुई कि मिड टर्म कॉन्फ्रेंस में भी आप लोगों ने इतना अच्छा अटेंडेंस दिया, और हमें उम्मीद है कि आगे जब मौका मिलेगा तो इससे भी ज़्यादा करके दिखाएंगे और आप लोगों को फिर से बुलाएंगे. धन्यवाद. सत्यजीत साहब ने एक रिमाइंडर दिया है कि एक चीज़ भूल गया हूँ, जिसके वजह से ही आज ये कॉन्फ्रेंस संभव हुआ है. मेडिकल कंपनीज हमारे, खास करके NRI या कौन सन है, जो भी हमारे प्लैटिनम गोल्ड डायमंड स्पॉन्सर, सभी को बहुत बहुत धन्यवाद. एनीबडी मिसिंग? ओके ओके. थैंक यू सर फॉर रिमाइंडिंग मी. प्रेस और इलेक्ट्रॉनिक मीडिया के बंधु भी बहुत बहुत धन्यवाद. जो audio visual Hari ji, and for the hotel management for providing such a good environment for our scientific celebration. Thank you.
Now I request everyone to please stand up for the national anthem.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता. पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा. विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा. तव शुभ नामे जागे, तव शुभ आशीष मांगे. गाहे तव जय गाथा. जन गण मंगलदायक जय हे भारत भाग्य विधाता. जय हे जय हे जय हे जय 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 हे.
Now I request everyone to please take their chair in the audience and request Satyajit Sinha to please continue with the scientific session. Thank you.
We're going to start the next session, and I would first like to call Dr. Sunil Parmar sir, Dr. Ravi Ranjan sir, Dr. Arvind Kumar sir, Dr. Ashish Kedia, Dr. Ravi Kant sir, please come on. Dr. Ajay Sinha, Dr. Nilesh Kumar, and Dr. Ratnesh Ranjan. And I would like Dr. Ashish Kedia to please take over the proceedings. Since Dr. Arshad Iqbal is not there, so the LOC has said who is here only we should give the prize. So I'd like to request again Dr. K.S. Gupta sir to please take out the ये नहीं डॉक्टर दीपक अग्रवाल नहीं प्लीज डू द ऑनर
मतलब वही निकल रहा है जो नहीं है ये क्या तरीका है
आकांक्षा सिन्हा
नहीं है
आकांक्षा नहीं है
ये वही निकल रहा है जो
स्लिप गया आकांक्षा सिन्हा नहीं है मनीष कर्ण है हॉल में है गया
हॉल में भी नहीं है क्वालिटी क्या होती है समझ नहीं सकता
प्रियंका कुमारी
बस
Good morning, everyone. We are late for this session already, so we'll continue with the next session on intermediate uveitis. I welcome you all to this scientific feast at a wonderful location in RAJGIR. For the next session, Dr. Sunil Gupta, who is the chairman for the session, and Dr. Ravi sir and Dr. Arvind sir will be co-chairing the session. Nilesh, okay. Without much, as we already late for the session, so there is some change in the sequence of topic. I invite Dr. Manisha Agarwal, who has a flight to catch, and so she'll be speaking first, and she'll be speaking on using steroids smartly in uveitis, followed by identifying masquerades learning lectures. I welcome Dr. Manisha.
Very good morning to all of you. I think we've been talking since the morning regarding the use of steroids in uveitis, and as Dr. Vishali mentioned, that use of steroids is not synonymous with uveitis. However, having said that, uveitis at the end of the day is a kind of inflammation, and I think steroids do play an important role and a very critical role in managing any case of uveitis. So I will start my talk by Dr. Devra that no one is allowed to die or go blind without a trial of steroids. And I think this is very valid whenever we are managing a patient of uveitis. So let's first understand what would be the goals of treatment when we are managing our patients with steroids. First would be that once we have ruled out infection or malignancy, ocular inflammation is the principal cause of complications in most of the patients of uveitis. The control of inflammation is the primary goal, and we have to do a kind of a firefighting to control the inflammation at its earliest. Of course, the other goals being early control of inflammation with minimal side effects of the drug, to prevent damage to ocular structures, and also to prevent long-term visual loss. Now let's understand what are the various modalities in which we can give steroids to our patients. The first being systemic steroid therapy, which is very commonly used. We can have a local steroid therapy, which can be in the form of a posterior subthenon tricot injection. We also have various kinds of implants available, and the most common that we use is the Ozurdex implant, which has dexamethasone. And now we are also talking of a suprachoroidal triamcinolone deposit, which is also being practiced by a few people. Now, when we are talking of systemic therapy in uveitis, we primarily have two phases. One is the induction phase and one is the suppression phase. The induction phase is the initial phase of control of active inflammation, where it is applicable to all cases of inflammation and you have to do it as quickly as possible. Where we go wrong is that we feel very comfortable by starting a small dose of steroids. However, the principle is that you have to start it in full dose. So it has to be 1.5 milligrams per kg body weight of your patient. So please get the weight done of your patient before you start the dose of oral steroids. And then of course the maintenance of control of inflammation in chronic inflammatory diseases after you've done a successful induction. For chronic severe diseases, a long-term suppressive therapy is the key to long-term success and good visual outcomes. So what would be the indications when we are going to opt for systemic steroids? One would be chronic bilateral diseases, which are going beyond the anterior segment. And when I say beyond the anterior segment, it means involving the other segments of the eye, like intermediate uveitis or posterior uveitis. Where the patient is resistant to your using a local therapy, that means you put the patient on topical but is not responding well. Eye diseases associated with any systemic disease, like you have a patient of rheumatoid arthritis or a VKH, you will need systemic steroids. Severe inflammation that is too painful or destructive, like we had in the morning, Dr. Somshila speak about scleritis, where again it is very painful and destructive, and we have to be very much on our guard to use systemic steroids in managing these patients. Now, when we talk of starting and tapering these steroids, this is a usual regimen that we follow, that we are going to give the patient 1 milligram per kg per day. And usual dosage would be varying somewhere between 60 to 80 milligrams per day. The usual tapering is what is recommended, but as a clinician, what I would recommend, that do not follow this tapering dosage in a mechanical way. However, you see the response of your patient to the ongoing treatment, and according to that, then you modify your treatment. As far as oral corticosteroids in children is concerned, you have to have short-term oral steroids. We have to be very quick in shifting them to immunomodulatory drugs and immunosuppression. Growth monitoring is very crucial, and if you are contemplating a long systemic steroid therapy, and generally such therapy would require the help of a pediatrician or a rheumatologist. Now these are a few case examples which I want to share. This is a 61-year-old female patient with pain and floaters in the right eye. For last 3 days, she had a yellowish mass in the superior nasal quadrant with exudative RD, and dilated conjunctival vessels were seen over this mass. And when we did a B scan, what we find is that there is evidence of exudative retinal detachment on doing the B scan. And on OCT, this is the OCT picture where you see the RPE undulations, you see the pocket of the subretinal fluid, you also see an element of vascular detachment. On doing a B scan, a very clear-cut T sign is not made out, but you have the evidence of scleral thickening, and you also see exudative retinal detachment. When you do a fundus fluorescein angiography test, you find that the disc is hot, and you also see some element of hyperfluorescence in the superior nasal quadrant, which is very much suggestive of an inflammatory pathology. So a presumptive diagnosis of a nodular posterior scleritis with exudative RD was made, all investigations were done, and the patient finally was started on oral steroids. 2 weeks follow-up, you find there is a beautiful resolution of this entire lesion which was seen in the superior nasal quadrant. Case 2 is a 24-year-old female patient with diminution of vision in the left eye for last 5 days. She was already on 2 months of antitubercular therapy for pulmonary TB. The CECT was still suggestive of active COX, and the Mantoux was very strongly positive. And this is what the left eye picture was, where you have a granuloma which is involving the optic nerve head. You have a huge granuloma in the superior nasal quadrant, and what is very typical of these TB granulomas are these very beautifully described lesions by the PGI group, where you have these petechial hemorrhages suggestive of early RAP lesions developing in these granulomas, because these are hypoxic granulomas and they are VEGF driven. On OCT, you find that there is an element of cystoid macular edema, and you can appreciate the granuloma. Now we started treating this patient with Avastin and moxifloxacin intravitreal injections, which we are giving every week. And we have done some work on managing these TB granuloma patients along with ADT and steroids, and you find there is a beautiful resolution of the entire granuloma. However, you have a fresh lesion appearing other than the original lesion. Now, what we basically identified this new lesion after the patient has been on ADT is a paradoxical reaction, which is an immune-mediated response, and we find that we have treated this patient with IVMP and stepped up the oral steroids, and there is a beautiful resolution. We have also in our study evaluated the VEGF levels in these patients, and we found them to be 5 times higher in those patients who are having a AMD-CNVM. So this is the timeline of this patient where you find that the vision was 636N12. You find that the patient had a huge granuloma. The patient was treated with ADT steroids along with intravitreal injections of Avastin and moxifloxacin. Why moxifloxacin? Because it is a second-line anti-tubercular drug as well. You had a paradoxical response, and this was subsequently treated with IVMP, and 2 weeks after IVMP you find that the patient has beautifully responded and has recovered a vision of 66N6. So this is the paper we had published where we had described the use of adjunctive intravitreal anti-VEGF along with moxifloxacin for the treatment of these intraocular tubercular granulomas. So coming to local steroid therapy, we can treat them for non-infectious uveitis in adults can be treated with local steroid therapy. Pediatric uveitis, patients not responding to systemic therapy, and also where we have the systemic therapy which is contraindicated, such as in pregnant females, diabetic patients, and psychiatric illnesses. The side effects of local therapy, I'm sure all of you are aware of, is rise of intraocular pressure and cataract formation. This is a 33-year-old young male patient with a history of left eye trauma with iron particle. The vision in the left eye was as low as hand movements, the right eye vision was good to 612, and now he started developing an inflammatory response in the right eye. The intraocular foreign body removal was done in the left eye, and what you find on fundus fluorescein angiography that there is these typical small pockets of subretinal fluid at the posterior pole suggestive of a sympathetic ophthalmia which started to develop in the right eye of this patient, which was the only seeing eye of this particular patient. So we started this patient on immunosuppression, and this is the huge pocket of the fluid that you are seeing. So the patient was treated with IVMP followed by oral corticosteroids, and we also started immunosuppressing this patient by using azathioprine. And what you find is that at presentation, the patient was 612. 4 weeks later, the patient was still at 612 because he still continued to have a small pocket of subfoveal fluid. And at this point of time, we decided to give an Ozurdex implant in this eye because we knew that we were dealing with a very high immune-mediated response in the form of sympathetic ophthalmia. 6 weeks after having given the Ozurdex implant, the patient did recover a vision of 6/9. And subsequently, there was a complete resolution of this pocket of fluid with a recovery of 66N6 2 months later. This is my last patient, again a young patient on systemic steroids, on ATT for 3 months, having high blood sugar levels and hypertension, weight gain, all complications of systemic steroids. And finally, we found that this patient was really not responding completely to the ongoing systemic therapy. He had these relentless active lesions which kept progressing, and finally we had to resort to giving an Ozurdex implant, and you find that there's a beautiful resolution of the choroiditis patches. So this is another patient of VKH again, which has been treated this was a pregnant female, and again systemic steroids were contraindicated, and therefore we had to resort to an Ozurdex injection, and the patient beautifully responded. So these are situations where in a normal course we would opt for a systemic steroid therapy, but sometimes our hands are tied and we have to resort to a local therapy. So I would just conclude by saying that these are a few principles to remember for smartly using steroids in your patients of uveitis. Firstly, assess the type of uveitis that you are dealing with. You must rule out that it's not an infectious uveitis. It is not an underlying malignancy as a cause of uveitis where you can really be having a very disastrous result, because there is going to be a delay in the diagnosis and in the management of the underlying malignancy. One principle that you all must remember is hit hard and hit fast. The induction phase has to be with full dose of steroids to control the inflammation, and a half-hearted dosage of steroids is going to be more harmful than beneficial. Maintenance with steroids or immunosuppressants for chronic uveitis is very important. The use of steroids has to be done judiciously with monitoring of systemic side effects, especially in children. And an early shift to immunosuppressants or to local steroid therapy should be very strongly considered when you are dealing with patients of pediatric uveitis. And consider local therapy when your systemic steroids are contraindicated, such as in patients of diabetes, or if you are dealing with a pregnant female with uveitis, you can always opt for a local therapy. So thank you once again, and this is in short the guidelines which we can follow for using steroids in our uveitis patients. Any questions, I'll be happy to take. Yeah.
Ma'am, in many cases of looking at the posterior uveitis immune driven, and we don't find any systemic findings. Even a thought process of just hitting them with suprachoroidal injection or an occlusive implant that you have done, and rather than for not using the systemic steroids.
So first of all, what the question is that if we are dealing with a unilateral posterior uveitis patient, whether instead of systemic steroids, if we can start the patient
without any systemic
manifestation. So we need to understand that systemic manifestations along with posterior uveitis is one set of patients, and another set of patients where you can be having posterior uveitis without having any systemic manifestations. Now, if you are having a systemic manifestation patient along with posterior uveitis, I think there's no doubt that you will opt for a systemic steroid or an immunosuppression. But in those subset of patients where you're dealing only with posterior uveitis, you have to be very sure that you are not dealing with any kind of a infectious pathology or a malignancy, as I mentioned. If you are very sure of that, the first line of treatment surely I would start is going to be a systemic steroid. Why? Because I can always monitor the response and I can always stop my medication in case my patient is not responding or worsening. However, if you have injected, there is no coming back. You cannot really take the implant out. Now, you have started the patient on systemic steroids and you find that the patient is not responding to your expectation but is responding, and you want to add more immunosuppression, then you have a choice. Either you are going to add systemic immunosuppression or you are going to be adding a local therapy. Now, in the last case what I showed, a young boy who had a serpiginous-like choroiditis, he was already on ADT and on steroids. He was having all side effects of steroids. He became a diabetic, he started gaining the weight, he had hypertension. Now, in that situation, in a normal course, we would have just continued the patient on systemic steroids and not thought of anything else. But here we have a situation where we are getting hassled by continuing a high dose of steroid. So then we have opted for a local therapy. But as the first line, I would not go in for each and every case of posterior uveitis.
Just to add, ma'am, that I have experience regarding suprachoroidal injections, and I do go by your dictum that when you are looking the uveitis, you should hit hard and hit more. And now it's few cases that I have around 3 to 4 years of follow-up, and I feel that once you are able to achieve a very, that is just a hypothesis that I feel that even if suprachoroidal injections are able to achieve a very high immunosuppression at a very local level. So might be that also, and if you give a systemic steroid, where you are going to achieve the same level and the
So I personally don't have much experience with suprachoroidal. I have nil experience with suprachoroidal, something which I am not very comfortable with. Maybe Vishali ma'am can add to it, but I would be very scared to use suprachoroidal transdermal.
Ma'am, what about immunomodulators? See, being a general ophthalmologist, we are very hesitant to prescribe azathioprine. Maximum I can go up to methotrexate 7.5 milligram per week. What all workup you should do before prescribing azathioprine or other immunomodulator is one, whether is it necessary to take the help of my internist before prescribing it, because we are not able to tell that all sorts of side effects that azathioprine or other immunomodulator endocrine is going to give. So what is your opinion?
Sure. So I'll just come to that question. We'll just take up a comment from Vishali ma'am on suprachoroidal trigger.
See, the suprachoroidal and posterior subtenon for that matter, anything which is depot and you can't take out, I'm not comfortable in giving in uveitis, because the problem with uveitis is, like today you make a diagnosis of VKH and after 2 years you change into tuberculosis and sometimes even after 2 months. What is idiopathic today? It keeps evolving with time. So I would not give anything which I am not able to take off. Next I am very comfortable because I am a PR surgeon. Anytime I feel there is a problem, I go in the eyebrow, we did not have to do it, and remove the DEXA implant. Oral steroids are in my comfort zone. Oral steroids are also, you can stop anytime. I will not go in a patient where I cannot retrieve it. So I have never done posterior subtenon canapod and suprachoroidal. Maybe for macular edema once the acute phase is over, but suprachoroidal not for treating the active disease, because I do not know what that disease could turn into.
Now, answering your question about immunosuppression, if you feel that you're not comfortable in starting a patient, I think the best is to have an internist in loop and then start it. So, because those patients, they need a regular monitoring of their systemic profile, like a liver function test, their blood profile. So, I would suggest that if you are not comfortable, please take an internist in loop and then start immunosuppression.
One quick point I would like to add. Unlike steroids, which you start in a high dose, like Manisha said, 1 to 1.5 milligram per kg, and then bring it down, immunosuppression is started in the low dose, like azathioprine. You start with 50 milligram. There is an enzyme PPMP if you can do, but most of us do not do. So what we do is we call the patients with complete hemoglobin, hemogram, and LFT after 2 weeks. If the counts are normal, you gradually step up the dose. The second myth about methotrexate or azathioprine, they will take about 1.5 months to start acting. So most of the time physicians start azathioprine, they expect magic, which does not happen, and then they say it's not working. It will take 6 to 8 weeks to start working. And that time frame has to be covered with oral or whatever form of steroids. And once they are started, there is no point giving it for 3 or 4 months in stop. It's minimum 2 years for non-infectious uveitis. That's the end point.
And just to add one more point, what ma'am has very rightly highlighted, that the patients that we get in our clinics often are the patients who have got multiple cycles of steroids. So they were given steroids, they resolved, then they again had a recurrence. So where we keep going wrong is that every time the patient has a recurrence, it is going to be more worse situation, more permanent loss of vision. So those are the patients, when you are starting them on steroids, side by side, as ma'am said, evaluate them for starting immunosuppression, and immunosuppression should be started before you have tapered it to a low level or stopped the steroids. We think we will stop the steroids and then we think of an immunosuppression. However, after you have started the steroids, you have to simultaneously start working and start the immunosuppression, because when you stop the steroids, the immunosuppression will then take over. But I think, answering to your question, sir, if you are not comfortable, please take the help of an internist and start these patients, but do not avoid starting immunosuppression. So my second talk for the day today is identifying masquerades and what are the learning lessons. I will just share a few of my cases. Now let's first understand what is a masquerade. So masquerade basically means a malignant process that simulates a benign disease. And so that is why when you are thinking, you keep thinking it's a uveitis case what you are dealing with, and ultimately it turns out to be a case of a malignancy, and that is something we really need to be careful of. So this is a 3-year-old young girl child presenting with pain and redness in the left eye for last 4 months. Diagnosed 4 months back as anterior uveitis and not responding to treatment. So I would like to draw your attention to it that when you are suspecting uveitis, I think there is absolutely no business for a uveitis patient not to respond to steroids. So that should raise an alarm that probably you may be dealing with some other etiology. So the patient was being treated with topical steroids and had already developed a secondary glaucoma, therefore was on AGMs and on hometropine. On examination, the child had a fixed and followed light. The slit lamp of the right eye was unremarkable, while the left eye showed mild conjunctival congestion, mid-dilated pupil because of hometropine, and the AC showed these typical fluffy white X-rays in the anterior chamber, which somebody had diagnosed as fibrinous response and was treating it as a case of uveitis. The central fundus of the child appeared totally normal. The B-scan was absolutely normal. So on examination, you find that the fundus picture appears to be absolutely normal. Healthy disc was there. However, the IOP was as high as 31 secondary to the topical steroids being used. So we took up this child under anesthesia because everything was not falling into place. A child with anterior uveitis being treated with steroids and still not responding. So we took up this child under examination under anesthesia, and we found that the entire ciliary processes were studded with white fluffy material 360 degrees. An AC tap was done. We were scared to do an AC tap, but we finally plunged into it with a long intracorneal track using a 30-gauge needle to avoid any spread of the lesion in case we were dealing with a malignancy. And finally, when the histopathology was done, it came out to be the histopathology did show of the enucleated eye with the ball implant was done for this child because it did show malignant cells. And the gross pathology of the enucleated globe showed fluffy white material in the anterior chamber over the ciliary body, lens nodules and anterior vitreous. And the histopathology showed basophilic tumor cells on the iris surface, and the entire ciliary body region, choroid and sclera were found to be normal, and the surgical end of the optic nerve was found to be free from the tumor cells. So this child apparently on cytopathology was proven case of retinoblastoma, and we further systemically evaluated. There was no evidence of any other malignancy. The child was not advised any further intervention because it was not a high-risk tumor on histopathology, and the child was reviewed by a pediatric oncologist, and it was diagnosed to be a diffuse anterior retinoblastoma. Now this was a very different kind of a presentation of retinoblastoma, what we usually see, and when we reviewed the literature, we found there is an entity of a diffuse anterior retinoblastoma, for which also the primary focus of the tumor is in the retina, but it may be of a microscopic foci which we cannot clinically diagnose, and therefore it becomes a diagnostic dilemma. It's usually sporadic and unilateral with a very slow progression with a poor response to the conservative therapy. So the lessons learned from this particular child's management was that here we had a young child with unusual fluffy exudates in the anterior chamber, but what is important is that the patient was not responding to topical steroids which were being continued endlessly for last 4 months, and the child had already developed a secondary glaucoma because the child was a steroid responder. Now this is the time when you need to revise your diagnosis or take another opinion, and like we plunged in this child, we took the child for an examination under anesthesia where we could do an interventional diagnosis by taking an AC tap and sending it for the cytopathology. Now this is a second patient of mine, a 72-year-old male patient with diminution of vision in the right eye for last 3 months, hypertensive on treatment for 15 years. He had a history of non-Hodgkin's lymphoma diagnosed in 2015, and as told by him, he was in the remission phase. Now he came to us with a diagnosis of uveitis and vitritis. He was on treatment with prednisolone acetate, Dorzox in both the eyes, and on oral corticosteroids for last 3 months because he had been diagnosed as vitritis and uveitis somewhere else. So on presentation, the left eye was pretty okay, but on the right eye, you see there is vitritis. You see some kind of a very hazy view is allowing you to see and appreciate a yellowish lesion, and beyond that, the details were not visible. So these are the reports. The patient had already undergone a gamut of investigations, thinking a patient to be a uveitis patient, and nothing was very significant or suggestive of anything else. Now our attention was all drawn to this small yellow lesion that we could see in the right eye fundus, and we tried doing an OCT through this particular lesion. Now on OCT you find a very typical finding that the deposit is sub-RPE, and which is again very classical of a particular clinical entity. We took up this patient for a diagnostic vitrectomy, and this was done after stopping oral steroids for 2 weeks. The vitreous sample was taken and sent for cytology and immunohistochemistry. Now, when the report came, it suggested high cellularity with sheets of lymphocytes. The impression that was reported to us was chronic on acute non-specific inflammatory reaction. And the lab again reported acute on chronic inflammatory reaction, no evidence of any malignancy was seen. We were not very convinced with the report, so we sent the patient back for a systemic evaluation to the oncologist, and the oncologist confirmed to us that there is absolutely no evidence of any active lesion. The PET scan was totally normal, and the patient was very much in the remission phase. Now, after 2 weeks of having done the diagnostic vitrectomy, we found that the lesion has now grown in size and has become much larger. And we were feeling very helpless that we are not able to really do anything for the patient. But to our uttermost shock, the patient now started developing multiple lesions even in the left eye, which was actually the normal eye of the patient when he had presented to us 2 weeks before. So you see these multiple clumpy lesions in the left eye. Apparently, we were able to get much better OCT pictures because now the vitritis apparently had cleared up, or the vitreous hairs had cleared up after our vitrectomy. And you see these classical sub-RPE deposits in the right eye, and you see these multiple deposits which are again at the sub-RPE level in the left eye. And this is how the patient was on fundus fluorescein angiography of the right eye, and on the left eye where you have this typical leopard spot appearance of the lesion. So we went ahead, we did a left eye core vitrectomy, again we sent the sample, again there was no evidence of these malignant cells. Now based on the clinical suspicion, we started treating this patient with intravitreal injections of methotrexate, and the injections were given in both the eyes. And you see the response in the right eye. On presentation, he had one lesion which had grown much larger in size after the diagnostic vitrectomy. And after having treated with 2 injections of methotrexate, the lesions had completely resolved in the right eye. This is the timeline of the left eye, where you have these multiple yellow lesions appearing in the left eye fundus. After 7 days, you find that the lesions are quite less. And this patient again had undergone 2 injections of methotrexate, and after 20 days of having treated the patient, you find that the lesions have completely disappeared from the left eye. So on follow-up, both eyes of course had intraocular lymphoma secondary to systemic B-cell lymphoma, and no new lesions were found till 6 months, and the patient did continue maintaining a vision of 6/6 in both the eyes. The patient was referred back to the treating oncologist for a re-evaluation for the reactivation of the non-Hodgkin's lymphoma, but he apparently showed no evidence. So this is what is in the literature, that they are older patients, they have a known history of systemic lymphoma, and there may be absolutely no evidence of reactivation of the systemic disease, but you can have an involvement in the eye. So the lessons learned from this particular patient was that here you had an elderly gentleman who is very unlikely to have the first episode of uveitis at such an increase, at an age of 70 years. The patient was not responding to the treatment of vitritis, which was being given in the form of oral steroids for last 1 month. And a clinical suspicion always takes precedence over all kinds of lab reports. We did the vitreous sampling twice from both the eyes. We did a PET scan and nothing was coming out to be positive, but based on our clinical suspicion and a very classical OCT picture, we diagnosed this patient as having intraocular lymphoma, and we started treating the patient, and he responded beautifully. And of course, a detailed history taking is of utmost importance because the patient did have a history of lymphoma, which again raised the suspicion in our mind. So I would just say that the eyes are useless when the mind is blind, and we always have to rely on our clinical suspicion. So I would just end my talk by saying that always listen to your heart. It may be on your left, but it is always right. Thank you so much. And just to answer your question, I'll just quickly share. This is one female patient who was being treated as a VKH patient somewhere else. She had been given IVFP, she had been given methotrexate, she had been given azathioprine, and she presented with a right eye vision of 1/60 in the right eye. The left eye was this, she had massive exudative retinal detachment with subretinal gliotic bands in both the eyes. And this is how her OCT picture was. We really didn't know what we were dealing with. We apparently thought we were dealing with CSCR, which had actually worsened on treating the patient with corticosteroids. And ultimately, this patient also, she came out to be a CA breast, both eyes, with metastasis in both the eyes. And we had lost 6 months, and we recently lost this patient also, because there had been an undue delay in the diagnosis and management of this patient. So I think this is something we have to really keep in mind, that when we are diagnosing a patient of uveitis, a patient not responding to steroids, you really need to go back and revise your diagnosis. Any questions, please?
Do we have any questions in the session? The ma'am would be leaving after this.
Thank you so much.
Thank you so much, ma'am, for that elaborate talk and showing us those very interesting cases. Next we have a very eminent speaker, Dr. Mudit, who will be speaking us from this online. Dr. Mudit is presently the head of vitreoretinal diseases at Dr. Prasad Eye Institute, Hyderabad. He is a well-known vitreoretinal and uvea specialist and is a recipient of numerous awards. He has more than 80 publications in peer review journal and is a reviewer for several international journals. I welcome Dr. Mudit, who will be speaking on clinical manifestations of infectious uveitis.
ऑन सॉल्व ऑपरेशन जितने भी ड्राइवर हैं उन लोगों को जो जहाँ पर कचरा पड़ा हुआ था वहाँ पर उन लोगों को खाना का व्यवस्था है। आप लोग अपने अपने ड्राइवर को प्लीज इन्फॉर्म कर दीजिए।
And can you see my slide and am I audible?
Yes, sir. Yes, sir.
Alright, so good afternoon once again, and first of all let me thank Dr. Sinha, Dr. Manisha and the entire Bihar Ophthalmic Society for having me here. I apologize that I can't join you physically in person and I'm connecting virtually, but hopefully the next time I should be able to join you for this great conference. And thank you for having me here. So I will be speaking about clinical manifestation of infective uveitis. So why do we need to know first of all whether what we are dealing with in uveitis is infectious or non-infectious? And the reason for that is pretty simple. Number one, sometimes while the appearance of clinical infectious uveitis may be very characteristic and you can recognize some patterns, often they may be nearly similar to how a non-infectious uveitis may present with. And you need to differentiate between these two because the treatment differs. We have already had some great talks on the role of steroids and immunosuppression in these diseases. But while steroids and immunosuppression are the treatment for immune-mediated or non-infectious uveitis, when it comes to infectious uveitis, treating just with steroids or immunosuppression can be counterproductive and can actually cause more harm. And therefore, it's important for us to initiate appropriate antimicrobial treatment for these infectious uveitis entities. And early and appropriate treatment can often result in much better outcomes in these cases. And I'll be showing you a few examples and how some of these characteristic infectious uveitis appear like. So this was one patient who had a nodular lesion over here in her retina, which was thought of as a scleritis. Initially, she had on her OCT, you can see the dominant areas over here, the subretinal fluid, elevation of the choroid. And inferiorly, you can see an exudative retinal detachment. Now, this patient was initially being treated with steroids, and the exudative RD worsened. The lesion did not regress. And when the patient came to us and when we examined her, what we found to our surprise was that this patient, apart from having a scleritis, also was a known case of abdominal tuberculosis and also was seropositive for HIV. Now, in patients like this who are seropositive for HIV but was not diagnosed earlier as HIV, was also a known case of TB. Just giving steroids or immunosuppression can be disastrous. So this patient was started on ATT again. This patient was started on antiretroviral therapy and subsequently over a period of time the exudative RD regressed. So this shows how important it is for us to identify underlying infections because treating them just with steroids can be devastating really. Some more areas now, how can clinical clues help us in assessing whether the scleritis that we see is infectious or non-infectious. The non-infectious ones may be the solitary sometimes or large lesions, but infectious, while they may present as nodule, abscesses or ulcers, can often be multiloculated. So you can have multiple lesions, number one. And you can see sometimes this first point. So first point, presence of multiple lesions not responding to the steroid. All of these are clues that you are dealing probably with an infectious neuritis rather than a non-infectious one. Moving on to some more cases. So this was one very characteristic case, and I will come to the pattern of how it is like. But this was a patient who was initially treated as a non-infectious uveitis, pan uveitis. This patient was initially given steroids. Visual acuity from 624 degrees to 660. Was then started with IVMP. The lesions did not resolve. Was subsequently given Ozurdex, and you can see these two Ozurdex implants also over here. But when the patient came to our clinic, what we found was these multiple biliary lesions that you can see inferiorly. And I will show some of these later on, but these biliary lesions are characteristic of ocular syphilis. We got this patient checked for TPHA and DDRL. Patient came up to be positive for TPHA, which is a trichodymal test for syphilis, also positive for DDRL. In fact, turned out to be also positive for HIV. He was a recreational drug abuser, and this patient was subsequently started on penicillin. The visual acuity, which was counted, which was close to face at the time of presentation, subsequently improved to 6.9 in both eyes. Again, a great illustration of how important it is for us to identify infections. And let me show you some more common classic patterns of infection, which we can identify just as clinicians and where we do not need to resort to increased lab investigation or expensive or complicated imaging. So just on the basis of your physical examination, you can unearth a lot of these clinical infections. Let me come to these. So if you look at how ocular TB presents, now while you may see granulomatous uveitis, but these peripheral synechiae, vasculitis, and these subvascular lesions are pretty classic of tubercular vasculitis. So if you see these subvascular pigmentary lesions, keep in mind one of the differentials of ocular TB. Dr. Vaishali has already had a great talk where she showed some of the cases of subficinous lymphocytitis, but the picture is pretty characteristic. Lesions which may initially be away from the disc, later on go on to coalesce, but a classic subficinous lymphocytitis. So you see these lesions and you know that probably you are dealing with ocular tuberculosis. Another example where just the clinical appearance may help us in assessing what we are dealing with. Some more common infections, toxoplasmosis. Now remember one very important point about toxoplasma. It is one of the most common causes of a unifocal retinitis, number one. Number two, lot of times if you see a reactivation, you will see a retinitis adjacent to a scar. So if you see a retinitis lesion adjacent to a scar, it kind of clinches your diagnosis as to the fact that you are dealing with a toxoplasma lesion. So unifocal retinitis can happen in immunocompetent as well as compromised hosts, involves macula, does not have a consistent direction of spread, can have a significant vitritis associated with it, but one more important clue is a retinitis which is adjacent to a scar. So you see that and it kind of clinches your diagnosis that you are dealing with an ocular toxoplasmosis. Now one very important, another clinical subtle clue is looking at the pattern of reactivation. So if your reactivation occurs at the edge of a scar, you are probably dealing with toxo. However, in tuberculosis, the reactivation occurs from within the scar. So if you see a reactivation within a scar, have in mind the differential of ocular tuberculosis, reactivation at the edge of a scar, toxoplasma. Some more classic clinical infections or infectious retinitis. So if you see a retinitis with multiple hemorrhages, areas of central clearing, vasculitis, this is how a CMV retinitis may appear to be, and this is what a patient of CMV retinitis will look like. Now one important point in CMV retinitis most of the times is that the amount of inflammation in terms of vitritis or AC reaction will be significantly less as compared to the retinal manifestation that you will see. And whenever you see that disproportion between an anterior segment and a vitreous inflammation and the retinal manifestations, you should look for the fact that the patient probably is immunocompromised and thereby unable to mount the immune response. So you see multiple areas of retinitis with very minimal vitreous response or anterior segment inflammation. That probably is a clue to the fact that the patient is immunosuppressed and what you are dealing with is a CMV retinitis. So these are how the classical patterns of CMV retinitis appear with this extensive retinitis in areas of hemorrhage, or sometimes what we see this picture over here as a prostate branchitis. So absence or minimal vitritis, Then a fulminant form which has got an extensive retinitis with hemorrhages. Now remember, in fulminant form, the cause of vision loss usually is a macular involvement. Whereas when you see a granular form, you need to follow these patients more carefully because some of these patients may go on to have areas of peripheral necrosis which may evolve into a retinal detachment. So these are patients who will need a monitoring to look for signs of an RD or a peripheral brain also. Perivascular form of what we have already discussed, frosted-band meningitis. This is the appearance of that, but remember it can also be idiopathic, can be seen in benchets, sometimes even in lymphomas, leukemias and in SLE. But you need to be aware of this presentation of frosted-band meningitis that can also happen in HIV patients. Coming back to a disease which is a lot of times identified by its clinical appearance. So if you see this retinitis, this ground glass retinitis with central clearing with these multiple biliary regions, think of syphilis. So pattern recognition becomes important over here. So if you see this placoid retinitis with these areas of small lesions in the periphery more aggregated over here. He has to reconnect. It is single patient and the test of choice is a triple test. Are my slides lost?
We lost a couple of slides. Can you just go back to the previous slides from the CLV retinitis?
Oh, so that I am not again. Yeah, so I am already. Yeah.
Just the previous
So I was
slide.
talking about the pattern recognition in syphilis. So what happens in syphilis is that you can have these characteristic lesions. Yeah. So when you see this ground glass retinitis with this multiple biliary regions, again a clue to syphilis. But these are the classic patterns of syphilis: a placoid chororetinitis, ground glass retinitis with multiple biliary regions, again multiple pinpoint lesions. When you see them, think of syphilis. In fact, syphilis is actually a great masquerade, and any sort of uveitis can be mimicked by syphilis. And therefore, we get syphilis testing done for every single patient who comes for uveitis care. So every patient who walks into a uveitis clinic, we test them for syphilis, and a test of choice is a triple test like PPHA, which has got a more than 90% sensitivity and specificity, and not just VDRL, which to our surprise has only got a sensitivity of around 70%. So a test of choice would be a triple test like PPHA, and these are not costly but very easily available tests in most centers. Also, VDRL is actually used to monitor the response to treatment. So a 4-fold reduction in titers of VDRL indicates a clinical cure apart from a clinical resolution. So to test for syphilis, get a triple test like PPHA done for all of our patients. So these are the biliary lesions I was talking to you about. If you see these lesions, you can see full thickness retinitis in a lot of these patients. And this full thickness retinitis biliary lesions are again a clue to of the syphilis. This was the example of the case which I was showing to you earlier. I will not dwell upon it in the interest of time. Post-retinitis, again you can see these multiple areas of retinitis, hard exudates. Over here the patient may give you a history of fever. Earlier, again predominantly have an immunocompetent host but can have a frequent involvement of macula or disc. One more very classic appearance of infective retinitis is acute retinal necrosis, which can again happen in immunocompetent as well as immunocompromised host. But what we need to remember is that you can have a significant vitritis in some of these cases, and you can see these confluent areas of retinitis in the periphery. So confluent retinitis in the periphery, moving towards the center over here, you see these lesions over here, a clue to acute retinal necrosis. Progressive outer retinal necrosis is a disease which we predominantly see in severely immunocompromised individuals. So CD4 count will be significantly compromised, and you will have minimal AC reaction again or a vitreous inflammation because of lack of immune response. Frequently involves the macula, but what you will also see is a perivascular sparing. So you see a retinitis lesion with a perivascular sparing, or what then leads to this mud rat sort of an appearance. Think of progressive outer retinal necrosis. Moving on to some causes of endogenous endophthalmitis. Now, candida usually appears as a unifocal or sometimes 2 or 3 solitary separate lesions. And when you do an OCT, you see this characteristic bulging of these exudates into the vitreous, or what was described as the rain cloud sign. and that can be easily discernible. Whereas aspergillosis usually ends up spreading more horizontally, and you may see this subretinal spread of the lesion over here. And just let me show you one case. So this was one lady who came to us with lesions in both the eyes, with this lesion extruding into the vitreous. Vitreous biopsy in this case subsequently did come positive for Candida, but even otherwise clinical appearance in itself should basically be able to start a suspicion of the fact that you may be dealing with an underlying endogenous center with Candida being a causative organism. This patient gave a history of a gynecological procedure and hysteroscopy a month back, and then subsequently she developed a decrease in vision. So you can see on an OCT over here, I think the lag, but if you see over here on the slide, what you are seeing are these two lesions over here, and subsequently on OCT what you may see is the lesion which may protrude into the vitreous subsequently. So when you see that appearance on vitreous, that's pointing to a Candida endophthalmitis. Are my slides stuck? And they are not moving over here, but they are moving on my laptop here.
So they are moving slightly slow than what you're speaking, so we are just lagging a couple of slides, but now it's fine, sir. We are seeing the aspergillus endophthalmitis slide.
The time being is stuck on the Candida endophthalmitis slide. You are seeing the aspergillus?
Yes, sir. We are seeing the aspergillus endophthalmitis slide.
Alright, so aspergillus on the other hand appears predominantly more as a widespread subretinal lesion. Nocardia is usually the diagnosis of exclusion, so we will not go much into that. But one more lesion or pattern is if you see these multiple lesions which may appear over here sometimes and then may regress unilaterally, and that may be a clue for DUSA. So just one case shows how important pattern recognition appears to be, and that is, I think we need to move on to the next slide over here. So this was one patient who was initially thought of as a CMV retinitis, but subsequently when we have a look at the patient clearly, this patient was planned for a biopsy which came out to be negative. But if you look at it, this patient had this lesion over here and the patient responded significantly to intravitreal clindamycin and bacterium DS. So this was a patient of toxoplasma, and I'll show you how pattern recognition becomes important in these eyes. Let me just show you one very good example of that. So this was a patient who had a retinitis lesion, triangular retinitis lesion in the periphery, was initially thought of as an acute retinal necrosis, was being treated with systemic antivirals. But when the patient came to us, we could see the scar at the edge of the lesion, and that made us think are we dealing with the toxoplasma. Started the patient on anti-toxoplasma regimen, and look at how the lesion started to regress. So the patient's toxoplasma lesions regress significantly after starting bacterial DS, and that is how identifying clinically retinal infections become so important. So a lot of times you can identify them just on the basis of a good clinical examination. All you need to do is keep these clinical tools in mind, which will help you identify a lot of them. Once again, thank you so much for a patient hearing and for having me here. And my apologies for not being there with you physically, and hope please to be there the next time. Thank you so much.
Thank you so much for such a wonderful talk, sir. You have shown us the entire gamut of infectious uveitis. Do we have any questions here? Dr. Avnesh? Nilesh? Okay, so we'll move to the next speaker for the day, Dr. Natasha Radhakrishnan. She is presently clinical additional professor in the Department of Retina and UV at Amrita Institute of Medical Sciences, Kochi, a recipient of PhD Gold Medal and a member of Royal College of Ophthalmology. She'll be speaking on clinical manifestations of non-infectious uveitis. Welcome, Dr. Natasha.
Hi.
Dr. Natasha?
To all?
Yeah.
Yeah. The field is coming in very irregular, so I'm not able to follow. Am I ready to start?
Yeah, you can go ahead. Please share your slides.
Good afternoon to all, and thank you for giving the opportunity. Am my slides visible?
Not yet, ma'am. Yes, now we can see the slides. Please go ahead, ma'am.
Okay. Okay. Thank you to Bihar Ophthalmic Society, Dr. Manisha and Dr. Satyajit Sinha for this opportunity. And today I will be talking about the type of uveitis that is non-infective uveitis. So most of these are immune-mediated inflammations, and they are related to systemic rheumatological diseases, sometimes as solitary ocular, important cause of visual mobility in adults and children. But in our country, we should never come to conclusions. We must always rule out infections before we go into the non-infectious uveitis. The common non-infectious uveitis that we can possibly it is the sarcoidosis, Behçet's disease, Fuchs uveitis syndrome, multifocal choroiditis, serpiginous, birdshot, and the more common PKH disease. When we look at the ankylosing spondylitis, it is mostly males and more than 8 years of age, acute recurrent uveitis that is bilateral and symmetric, and most of them are positive for HLA-B27 and RF negative, and they present with a severe reaction, acute anterior uveitis and a hypopyon formation. The diseases of inflammatory bowel disease, Crohn's disease and ulcerative colitis can also present with a mild arthritis in childhood. They also present with acute anterior uveitis, and they are symptomatic anterior uveitis. I will not deal with the pediatric entities in detail because I believe we have more talks later on. Sarcoidosis can present most commonly with anterior uveitis, can also have the aromatic precipitous iris nodules, peripheral and broad-based posterior syndicate, complications of band-shaped keratoconus, cataract and glaucoma. Inflammation in the posterior segment is in the form of retinal vasculitis or multifocal choroiditis. So the classic candlebag strippings of pericarditis can be seen in sarcoidosis as you see in these pictures. Serum H and serum calcium will give us a serological diagnosis, MANTO will be negative, and an HRCT meaning hilar lymphadenopathy. Of course, for tissue diagnosis, you need a lymph node biopsy or a bone. Behçet's again presents with a hypopyon uveitis, sometimes arterial and venous vasculitis, retinal infiltrates, and it's characterized by several relapses, and finally can end up with sheath vessels, diffuse chorioretinal atrophic changes and optic atrophy, as you can see in this picture, and end-stage Behçet. The systemic lupus erythematosus presents with sometimes anterior uveitis, sometimes pan uveitis, and the most devastating complication that occurs is the occlusive vasculitis. So, vaso-occlusive vasculitis, where there is occlusion of the arteries as well as the veins in the fungus. The ANA profile in the apna needs to be done, and most of the time treatment is along with the rheumatology consultation. One of the conditions of non-infectious uveitis that we commonly encounter is the PKH. It is a granulomatous pan uveitis that is usually bilateral. Preceding neurological symptoms of headache, neck stiffness, and tinnitus may be there, and late onset skin changes like vitiligo and maybe oral depigmentation. It usually has a mild vitritis with exudative retinal detachments and dyschedema. The fluorescent angiogram is very characteristic with the pinpoint leaves that then enlarge and coalesce. And if you do treat it late, it can cause the sunset glow fungus and pigmented appearance at the end of the treatment. The differential diagnosis of PKH would include multifocal CSR, TB, exudative detachment, posterior scleritis, and sympathetic ophthalmia. Let us look at this case, a 45-year-old female that presented with blurring of vision in both eyes and some shallow angles as well. Plus one cells and flare in the bone varies in dyschedema and multiple sensory neural detachments in the fungus, and crucial diagnosis of incomplete PKH was made. So this was at recitation, and these were the OCT and the fluorescent angiogram with the sleep and the pinpoint leads. The patient was started on systemic medications of prednisolone and MMF and steroids and cyclopentins topically. At 1 month follow-up, you can see that all the sensory neural detachments have resolved, the dyschedema is resolved with not much of depigmentation either. And this was the resolving sensory neural detachment. So this was fairly successful management of the VKH patient. On the other hand, this is a 40-year-old lady who presented with what looked like VKH, again pinpoint leakages, sensory neural detachments, disc edema. After starting her on immunosuppression, she came back about 3 weeks later with severe lymphedema and orbital cellulitis-like picture. So here we had not ruled out tuberculosis before because the clinical picture was so suggestive of VKH. And she came with multiple new lesions in the fundus with sensory neural detachment as well. And she turned out to have a mantle strongly necrotic positive, and PCR of the active subsequently was TPD positive. So this is just to further reinforce that we cannot afford to not rule out tuberculosis when we are dealing with non-infectious uveitis. So a thorough clinical evaluation and systemic review will be needed, and then a diagnostic workup ruling out the infective pathology, and then you can go on to the imaging techniques. Lab investigations, the step 1 is just a baseline workup. The step 2 should be guided by your anatomical classification by the clinical findings and the medical history. And the step 3 would be more extensive and sometimes invasive investigations. And the treatment algorithm will be local and systemic therapy, control the active inflammation, the systemic therapy to avoid recurrences, and also management of the ocular sequelae. And we have for a quick control of the disease, we need, like Manisha ma'am said, high dose of steroid and fast it will be implemented. But for a longer control, we need an immunosuppressive agent like an antimetabolite, like other country methods agents, or sometimes we need to go on to higher amount of immunosuppression as in the biologicals. Local steroid therapy may be required, topicals of course, then we have the posterior subcutaneous or the intravitreal implants. And they are usually done when there is bilateral presentations, when there is a non-rem steroid, non-responders, and when you pay off treatment. Poor response to immunosuppressive therapy should warn the clinician that the diagnosis may not be correct, and also rule out masquerade in elderly and epileptic patients. It's important for us to treat the ocular sequelae as well, cataract surgery, PSC removal after control of the inflammation, anti-VEGF pan-regional propagation may be needed if there is neovascularization, sometimes vitrectomy in case of vitreous hemorrhage. We also need to keep a keen eye out for sequelae, like this patient was a diagnosed case of VKH on immunosuppressants, regular follow-up, maintaining 6/6 vision, then came with a sudden blurring of vision, so we thought it was a recurrence of activity. But the fundus picture was just a small PED-like lesion at the fovea with a small amount of fluid as well, and it was actually a choroidal neovascular membrane that came in after treatment of VKH, and it resolved well with anti-VEGF injections. So take-home points in diagnosis of non-infectious uveitis, we need to rule out infectious causes and close monitoring of response to treatment, and if it does not respond, you need to reassess. Long-term systemic immunosuppression is absolutely essential, and timely referral to a uvea specialist in critical cases, close association with the rheumatologist will be required. Thank you all for your patient hearing.
Thank you so much, Madam, for that wonderful lecture. Do we have any questions here? Nilesh? Nilesh?
Hello. So in cases of VKH where the clinical picture is something confusing with CSCR, specifically typical CSCR having multifocal fibrinous reactions. So how do you approach such cases to start with the treatment? Am I audible?
No, actually I'm absolutely unable to hear.
So my question is like...
I think someone in the audience can probably answer that question.
In cases of VKH where the clinical picture is confusing with CSR, especially atypical CSR where you get the fibrinous reaction, multifocal fibrinous reaction. So how do you approach such cases to start with from treatment point of view?
If you think it looks like multifocal CSR, how to differentiate?
With fibrinous reactions.
Yeah, some
in such cases.
Yeah, one of the clues is that there will be no inflammation at all. So there will be no AC cells, no vitreous cells in multifocal CSR. The second clue would be that there will be no disc leak. When you do the floral planogram, it kind of clinches the diagnosis because the disc will not leak in multifocal CSR. And another clue is that in multifocal CSR, it is usually discrete areas of leakage that you will see. Unlike leakage where there is multiple small pinpoint leakages that then coalesce to form. So in multifocal CSR, usually under each of those SNDs, you will get one ink-blot kind of leakage. Those are the clues that help us to differentiate the two. And presence of fibrin also. Presence of fibrin in these lesions also suggests that it is multifocal CSR and not leakage.
So recently I had a patient where all the investigations were suggesting a diagnosis of leakage. The patient was started on systemic steroid. A patient diagnosed as leakage was started on systemic steroid. After 2 weeks of follow-up, one eye is improving, so fluid is decreasing, but the other eye fluid has increased. So do you think it could be a case of coexisting CSR also, or should I continue with the systemic steroid for some more time? One eye is improving.
Really sorry, but I can't hear you.
We will take the discussion a little because we are running short of time.
We are running short of time. Hello. We are running short of time. We'll go to the next speaker. I'd like to invite Dr. Reema Bansal, who is Assistant Professor at Advanced Eye Center. She is a renowned vitreoretinal and UVS specialist and has numerous publications. Her major area of interest is imaging in retinal and UVL diseases, and we are very fortunate to have the same topic here, same topic from her, which is imaging in uveitis. Dr. Reema.
Hello.
Yeah, we can hear you.
Good afternoon. You see my slides?
Yes.
No.
It is
Good
not
afternoon, everyone.
the slides are not visible yet. Please.
Slides can you see?
No, not yet, ma'am. Please share. Please share. Yeah. Please share your screen. Yeah.
So good afternoon, everyone, and thank you to Bihar Medical Society, especially Dr. Satyajit and Dr. Manisha for having me here to talk about imaging in uveitis. So this is one topic where books have been written. So I'll be touching the very basics of each imaging in this presentation. So we know that the imaging in uveitis is backbone of uveitis workup both for anterior and posterior segment inflammations. They help in not only making the diagnosis but also ruling out certain differential diagnosis and monitoring the inflammation during the follow-up once you start the treatment. And besides clinical care, it has extreme academic importance for teaching purposes, particularly those who are in institutes or colleges, and for reporting these cases for publication, especially the challenging cases. And for all practical purposes, for making these presentations where we all share our cases with each other. Coming to the anterior uveitis, we have these different kinds of presentations. So when the patient is in front of you, it's very important that we are very instant in starting the treatment and ordering the investigations. But at times what we forget is document them. And later on it's difficult to monitor the response to therapy. So it's important to clip these anterior segment photographs for documentation and for follow-up purposes. So this is the granulomatous uveitis where we had these baseline imaging of anterior segment slit-lamp photography, and this is the response to treatment after the topical treatment was started. So coming to the imaging, especially in posterior uveitis, conventional ones are fundus fluorescein angiography, ICT angiography, spectral domain, which followed the time domain, and the ultrasound and UVA. So these were the conventional imaging modalities which were later on followed by, as the imaging tools were followed by fundus fluorescence, swept source OCT, wide field, and the ultra-wide field fundus photography and angiography, and OCT angiography, which is the iris angiography. So coming to the role of fluorescent angiography, which I find has the most important role in imaging in uveitis. It has a very well-established role in clinical practice for diagnosis and management purposes. It helps to differentiate active from inactive uveitis. Also helps in diagnosing coexisting pathologies like cystoid macular choroidal neovascularization, etc., which we may not pay attention to when we are initially diagnosing the patient. It helps us in identifying areas of capillary non-fusion and retinal ischemia, as well as retinal neovascularization and various posterior segment inflammations, and of course helps to monitor response to therapy. So coming to the retinal inflammations, some of them may not be very easy to diagnose, especially when you have a patient presenting with this kind of vitritis bilateral, more on the left side, and the patient has blurry vision on focus, but all that clinically you can see is nothing more than vitritis. But when you do a fluorescein angiography, you see there is active vasculitis, small vessel, large vessel, all the vessels are involved, including the disc hyperfluorescence. So this is where you realize this is actually a case of bilateral vasculitis and Behçet's disease, which you would not have been able to diagnose in the absence of fluorescein angiography. So clear-cut case of vasculitis is easy to diagnose, but what we missed without angiography are the areas of capillary non-effusion which have to be treated. This is a case of bilateral exudative maculopathy. Some of the vitreoretinal practitioners may not think of a uveitis entity here because this is a lot of exudation and you really don't know what's happening. But once you do a fluorescein angiography, you have those retinal aneurysms all over. This was a case of idiopathic retinal vasculitis, aneurysms, and neuroretinitis, that is IRVA. Coming to the choroidal inflammations, we've been hearing about VKH. So this is the classical presentation of acute VKH where you have multiple pockets of subretinal fluid, and it helps to confirm the diagnosis and also to differentiate it from the very common differential of multifocal CSR. This is how the multifocal CSR looks like, and I believe there was a question in the last talk regarding this. So you have these white areas where somebody might mistake it as choroiditis, but look at this dark spot, which is a very important sign in multifocal CSR, and if you do a fluorescein, which is absolutely different from that of VKH, you have multiple points of leaks here and there. So this is, now that we have ultra-wide field imaging, why do we need that? The standard fundus camera typically capture only 30 to 50 degrees of the central fundus. The optos, which is the ultra-wide field, catches up to 200 degrees, which is more than 80% of the retina in a single image. So this is an example. This is an image which I have cropped from the ultra-wide field optos imaging, and the circle shows the part that would have been seen by the conventional fundus camera. But if you really look at the optos ultra-wide field, you have all these lesions of surfaces like choroiditis and the periphery. So this is important, and what is more important, in one capture you have all the lesions seen simultaneously. So the optos technology is designed to operate through a pupil diameter of 2 millimeters. So in uveitis, since we see a lot of patients with complicated cataract, posterior synechiae, small pupils, difficult to dilate. So this technology should be preferred to the conventional camera, where you want to see the posterior segment. So this is an example of a young boy who was diagnosed with panuveitis due to Behçet's disease. He was a known case, and he had multiple synechiaes, pupils would not dilate, and every time we would need to evaluate his posterior segment. So this was when we didn't have the ultra-wide field imaging. So this is the photography with the conventional camera, and when we compared it, when we acquired the ultra-wide field, we saw this is what we could capture without doing anything to the pupils. So you can see the lesions all over the fundus and both areas. And moreover, if you do the fluorescein, again we have inconclusive when we do it on the conventional camera. But when you do on the optos, you can see the vascular involvement all over the fundus. So ultraviolet field fluorescein angiography is an add-on, definitely. It allows simultaneous evaluation of the peripheral and the central retina, avoids the field overlap for montage that we need to create with the conventional fundus cameras, and of course it has an added advantage in small pupils and even in pupils along with complicated cataract, where the media opacity is a significant challenge. Coming to the fundus autofluorescence, too much of role in retinal diseases, but of course in uveitis, the single most foremost example is monitoring and diagnosing the patient of surface like uveitis. You have these lesions all over the fundus on the left eye, but I'm showing these 4 images just to show how we monitor on fundus autofluorescence these patients of tuberculous surface like uveitis. OCT, we all know the role of OCT in diagnosing and monitoring response to therapy in cystoid macular edema. But coming to the specific role where sometimes it just becomes invaluable. This was a patient, young, middle-aged female with a known case of PKH who was treated with steroids and immunosuppression. 6/6 vision, the fundus looks normal, and she just complained of mild discomfort in the eyes. And she said she's having some heaviness in the left eye. So could have been ignored because the vision was 6/6, no cells in the gaze segment or posterior chamber. The fundus examination was normal. So we thought let's do a fluorescein. Fluorescein just showed some kind of mild disc and fluorescence, no lesions in the fundus. But when we did the OCT, this was on the hyperlocal spectralis. The top scan is of the right eye. You can see the choroidal thickness is low. But the bottom scan is of the left eye. You can see the choroidal thickness is massively increased. So this is the reason why she was complaining of heaviness in the left eye. So this was a subclinical recurrence of leakage in the left eye, which we could diagnose only with the help of OCT. So these are some of the granulomas or nodules that you see in the fundus. In no case of skin disease, sarcoidosis, patient with lymphomas. So these orangish nodules are best seen on the OCT, where you can see these space-occupying lesions within the choroid. So these are nothing but choroidal granulomas. And when you see these RPE curves, below the RPE, you have these vertices. These are suggestive of lymphoma. And this is how these resolve with treatment. OCT angiography, you have some of these complicated cases where you see some scarring in the macula. You have these sheath vessels, and probably it's a hint to choroiditis and to vasculitis. We are not sure whether any activity is going on or not, because when we do the OCT, there is some kind of cystoid macular edema. So should we do a fluorescein angiography? We did a combined fluorescein and ECG. And in the early phases, we don't have much information. There is subtle hypofluorescence. And in the late phase, ECG is just showing some hypo. And there is cystoid macular edema on the fluorescein and some kind of leakage, focal leakage with this hypofluorescence. But when we do the OCT angio, we see a neovascular complex. So there was an outlying choroidal neovascular membrane which may not be visible on fluorescein angiography. So this is where the OCT angiography helps us. Some of these peripapillary skin lesions are also best seen with the OCT angiography. And this was a follow-up case of surface like uveitis, where we saw the disc was extremely hyperemic. We couldn't really appreciate the vessels, but we did suspect the vessels. We did fluorescein, and we saw some hyperactivity in the disc. And when we did the OCT angiography of the disc, we saw this huge network of disc vessels. Ultrasound biomicroscopy is indicated in opaque media and those with hypotony. Assessment of structures are not really accessible with routine examination method in these eyes, where you need to check for iris, ciliary body, pars plana, and peripheral images. So these are some of the structures that we have to see when we are not able to examine the fundus because of complicated cataract, media opacity, or whatever. So ciliary body and ciliary processes, this is how they look like. And you have a symphatic membrane which can be easily picked up on the UVM. You can look for the supraciliary and suprachoroidal occlusion and even ciliary body cysts on UVM. Also for the symphatic membranes, look into areas and to check all the quadrants to see the extent of damage, and especially in eyes with complicated cataract and hypotony. And a ciliary body mass, again useful, detected by the UVM. So we scan ultrasonography, again in hazy or opaque media where you have cataract, you have dense vitritis, or you have a vitreous hemorrhage for any underlying fibrovascular proliferation or tractional or a combined retinal detachment. So posterior scleritis is best seen on ultrasound with the classical T sign. And for the differential diagnosis of various intraocular tumors with the classical presentation of converting melanoma. So fundus photography I am talking about in the end because I find it as the basic and the most
चलने देना तो रोकना मत किया तो लोग साइड पर हरी जी
course the symptoms of health. And this is how we do in esophageal cystitis. Also the scarring is a good indicator of good healing of the scars. And for any surgical interventions in uveitis, pre and post-operative, especially those eyes undergoing fast vitrectomy, this is a case of TRD with vitreous hemorrhage because of TB vasculitis, and this is the fundus after the surgery and good laser. So to summarize, we have many imaging tools for uveitis, both for interior and posterior, but we need to choose the modality which is relevant to the morphology of uveitis and the site of inflammation, and of course depends upon the availability of the imaging tool in a particular sector, and extremely helpful in diagnosing and monitoring response to therapy. So thank you very much.
Thank you so much, Madam, for taking us through all the newer instruments and showing those beautiful images. I'm sure we all have those instruments, but using them judiciously and interpreting them is also very important. Thank you all the speakers, and I'd like to thank Dr. Sunil, Dr. Ravi sir, Dr. Arvind sir, and all the panelists for being there all throughout the session, and all the listeners for being there. Thank you so much. Due to a paucity of time, we are not taking any questions, madam. Thank you.
Thank you, Ashish. We want to complete the online platform, so we'll switch session 4 with session 5. And thank you, Rima. Thank you, ma'am.
Thank you.
So I would like to call Dr. Amitabh Singh. Dr. Amitabh Singh is here. Dr. Vivek Kumar. Dr. Gautam Garg. Dr. Neha Kumari. Dr. Naresh Prasad Singh. Okay, so I'd like to first invite the first speaker, Dr. Parthu Pratim Majumdar. Dr. Parthu, you're there?
Which go?
The connect कीजिए. Dr. Vivek will take over the proceedings.
Good afternoon. Now the next session will be immunosuppressive therapy. Can I start? Good afternoon. The next session will be immunosuppressive therapy, uveitis. The presenter will be none other than Parthu Pratim Majumdar, sir. Over to you, sir, for the presentation.
Yeah, good afternoon, sir. Am I audible and my slides are visible?
Yes, sir, you are audible.
Yeah. So, hello everyone. First of all, I would like to thank Dr. Manisha Agarwal, Dr. Satyajit Sinha, and all the executives of Bihar Ophthalmological Society for having me in this symposium. Yeah. So, symposium, it's an honor and privilege for me to speak before this August gathering. So, immunosuppressive remain a crucial part of the uveitis, and many a times you cannot manage a case of uveitis if you don't use immunosuppressive at right time. So, though many of us are reluctant and often afraid to use immunosuppressives, using these agents are actually not a rocket science, and though you need to be aware of the safety and mitigation of such agents. Now, a clinician must know when to use them, why to use them, and how to use them. So the most important criterion for the use of the immunosuppressive is non-infectious uveitis. Though there are several exceptions, but let's make it simple that the immunosuppressive should be avoided in infectious uveitis. Now, what are the indications of immunosuppressives in non-infectious uveitis? So you have to remember 4R of non-infective uveitis. The first is the recurrent attack of uveitis. The classical example is HLA-B27 associated uveitis. Now there is a term called corticodependence. So corticodependence is a very concerning term. It refers to reactivation of inflammation after suspending or you stop the steroid therapy. So however, most of the time this kind of corticodependence happens when you taper the corticosteroid too much or too fast, then it happens. So the next R is resistance to oral steroid. Now the most you have to understand that sometimes there is a recurrent attack of uveitis. Classical example is your HLA-B27 associated uveitis. So also you have to remember that the corticoresistance often a term where there is a loss of efficacy of the corticosteroid therapy after inappropriate administration. You are using the drug 1 to 1.5 mg oral dose per kg per day at least for 20 days, or for example you are treating a case of anterior uveitis using topical steroid every 1 or 2 hours for last 5 days and there is no response. So these are the times we often define that there is a corticosteroid resistance. So these are the times you have to consider immunomodulation in such scenario. So what is the next R? The next R is steroid related side effects. Now I am sure I don't have to tell anyone about the side effects of the corticosteroid. So immunosuppressive are the severe for patients with uveitis who are poorly controlled diabetes, hypertensive. So these are also important when we deal with the cases with steroid responder. So classical example is uveitis with steroid response glaucoma. So in such scenario, starting immunosuppressive early can actually help these patients. The last R, as I told, is the children. So children are the notorious to develop corticosteroid growth retardation, corticosteroid-induced glaucoma and cataract. So if you want to take one part from this 8-minute presentation, then it should be the use of immunosuppressives in children. You must use immunosuppressive in non-infectious cases of uveitis in children. Now there are some situations where immunosuppressives are considered as a first-line choice. Like these are Behçet disease, sympathetic ophthalmia, Bob-1 inherited disease, necrotizing scleritis due to autoimmune or non-infective idiopathic causes, juvenile idiopathic arthritis, pars plana in children. So these are the conditions you should use immunosuppressive as a first-line therapy, not with steroid first and then shifting to immunosuppressive. Directly you should go to the immunosuppressive therapy. Now with the advent of the newer human monoclonal antibodies, biologics have replaced immunosuppressive in certain conditions such as Behçet disease, juvenile idiopathic arthritis, but however the immunosuppressive remains a time-tested and relatively safe option in uveitis. So now it's important to understand how these immunosuppressives work. The key differences with here is that what is the difference between corticosteroid and immunosuppressive? Here you have to understand that the corticosteroids are not cytotoxic to the lymphocyte. They don't kill the lymphocyte. Instead, the corticosteroids redistribute the lymphocytes, especially the T lymphocytes, from intravascular space to extravascular tissues like spleen, bone marrow, and lymph nodes. And whereas immunosuppressives act in a different way. For example, if you coming to the antimetabolites, we all know that all cells need some molecules to grow and survive inside our body. So now antimetabolites, what they do, they mimic these molecules that a cell needs to grow. Now cells are tricked into, after taking the drug, the cells are tricked into taking this drug instead of taking this molecule. So that's how they actually damage the cells by by impairing the metabolite of the cells. That's why they are called anti-metabolites. Now coming to the cytotoxic, or these are comprising of mainly alkylating agents. So they prevent the cells from reproducing by damaging the DNA. So what they do, the alkylating agents, they add a alkyl group into the guanine base of the DNA molecules. So that will cause breakup of the DNA, and that's why the cells cannot multiply. So the immune cells cannot multiply and prevent the inflammation, subsequent inflammation. So for example, the other group is T cells, where this cyclosporin and tacrolimus, they act by inhibiting an enzyme called calcineurin, which is necessary for the T cell activation. So this group of agents suppress the immune cell response by inhibiting the T cell activation and cytokine production. So now you have understood the mechanism of the immunosuppressive. You must know the limitation of these immunosuppressives also. Sadly, these molecules cannot be used for the treatment of acute severe inflammation, where you need immediate onset of action by the drugs. So as you can see here, that from this table, that they take a longer time to achieve the desired mode of action than that. For example, methotrexate takes 10 to 12 weeks before it starts functioning. So you cannot treat a case of acute anterior uveitis due to HLA-B27 with methotrexate. So this is a very important limitation you must remember while deciding a case of immunosuppression. Now, as a clinician, you need to spend more chair time when you are planning to use immunosuppressive. The patient should be explained the need of the drug, the risk and benefit aspects of the therapy, and more importantly, the written and informed consent from the drug, countersigned by an attendant. So in Shankar we use such an immune consent for all our patients before starting the immunosuppressive. Now, all these drugs should be taken under care of an internist, and I always mention and tell my patients that use this drug while under the care of your family physician. So the patient should be regularly in touch with the family physician while taking the drug, and also all the parameters, for example, blood count, liver function test, in case of methotrexate, azathioprine, should be monitored immediately. Now, risk of severe myelocytic suppressions, which is indicated by sudden drop in the blood counts, should be explained in patients whom you are going to prescribe the azathioprine. And this patient ideally should check the blood count every 50 days for initial first 45, 30 or 45 days. So as methotrexate, azathioprine, these drugs are hepatotoxic, it is important to tell them that not to be drinking with driving and using this immunosuppressive also. Now, purpose of the reproductive age groups should be warned about the possible teratogenic effect of these drugs and advised to use proper contraception. Similarly, risk of infection and proper doses of the drug is very important. And this is very true with oral methotrexate, as oral methotrexate is often almost always prescribed weekly, so not daily. So I know two patients who missed the interpretation and developed severe hepatic dysfunction following taking the methotrexate daily. So this is very important to explain this medication, the doses regimen in the patient's own language. This is my last slide. You have to be developing country. You should not kill the patient by me. So always you need to understand that the cost of the drug, the outpatient, when the patient gets reported, the patient will be taken for 6 months at long back. So here it reflects the cost for 1 month therapy by a standardized regimen used for an average period. So you can see here microcontroller is little expensive. So you have to consider these aspects before deciding the treatment. Thank you for your patience.
Thank you, sir, for the very nice presentation. It was really enlightening. We came to know when to use immunosuppressive. Any questions from the audience? Due to paucity of time, we will move to next presentation. Thank you, sir. Thank you very much.
Topical, we can use the topical can't hear it, sir. I'm sorry.
Topical immunosuppressive drug you can reach. Topical.
Sir.
Topical immunosuppressive.
Sir, mic अपने तरफ.
Sir, he is asking.
Yeah, topical immunosuppression. What I understand, you are asking me about the topical immunosuppression?
Drug we can use in this
और
case.
पास लाइए mic.
He is asking in which case he can use topical immunosuppressants.
Yeah, so what I understand that you are asking me about topical immunosuppressive. Unfortunately, we don't know effective any topical immunosuppression that can control the posterior DPI. So the use of the topical immunosuppressive is much more limited, but we are sure that the new molecules will be coming.
Tacrolimus has been come in market, anti-cancer drug, tacrolimus.
Yeah, very good.
We can
different topic and the cyclosporins are available.
We can use in this case.
You are asking me about the topical tacrolimus and the cyclosporins.
इसमें varieties में यूज कर सकते हैं immunosuppressant के रूप में.
Sir, he is asking, can we use tacrolimus as topical drug for uveitis?
I think why is that? Why is this
Sir, can you hear us?
Why is this muffled? I can't hear it.
Okay, sir, I will mail you the question, you can reply. Thank you. Due to paucity of time, we will move to next presentation. Dr. S. Balamurugan, do's and don'ts in uveitis.
Lesson good afternoon to one and all. And is my voice audible to everyone there?
Yeah, it's audible, sir.
Thank you for coming. At the outset, I would like to thank the organizers from Manisha and all the members for giving me this wonderful opportunity to present my experience on this do's and don'ts in uveitis practice. I am Dr. Balamurugan and practicing at RAJGIR Hospital, Pondicherry. So, at the outset, I would like to say that taking the opportunity is something very important. Several concepts, more innovative as well. Because to learn from the mistakes.
Sir, please share your slides. We are not able to see your slides, sir.
The control mistake. That control actually entered.
Recording in progress.
So similarly, in uveitis, the choice of steroids and cyclosporins really matters. In steroids, we have a short-acting steroids and a long-acting steroids.
Dr. Bala, we cannot see your slides. Dr. Bala,
May not be an ideal option.
we cannot see your slides.
Clear?
Allah, you have to upload your presentation. Screen is not. Share the screen.
तो सर बोलिए अपना वीडियो कम कर रहा है
Can you Can you switch off your video please and only put on the presentation? Okay, so can you share your screen again please? Dr. Bala, can you please share your screen?
Yes, sir. I do that, but
I think your bandwidth is also less, so you can switch off your video. Okay, so we'll come back to you. We'll take the next speaker, Dr. Amitabh, please. इसको switch कर दो. We'll come back to you, Dr. Bala.
Good afternoon. I feel very honored to be back to my home state where I belong, and for this I thank the Bihar Ophthalmological Society and Dr. Satyajit for this opportunity. So, I have no financial interest in my presentation, and I will be speaking on cataract surgery and uveitis eyes. So this is a slightly different situation as compared to a normal cataract surgery. So my talk will focus on the SOPs which we should follow when we are putting a uveitic eye under the knife. So I have no financial interest in my presentation, and the most important prerequisite for a uveitic cataract is for the eye to be quiet for at least around 3 months. So if you have cells in the anterior chamber, that is an absolute contraindication for cataract surgery. If you have a flare, you can still go ahead with surgery. So since this is a special situation, you need to explain the procedure to your patient. And because the prognosis may not be as good as a normal cataract surgery, so the prognosis needs to be clearly explained to your patient. And in this modern day of litigation, it is a wise decision to take a written informed consent for all the procedures which you're going to do. So all these patients, they would need to undergo surgery under steroid cover or immunosuppressive cover. And steroids could be in various forms, either orals or periocular or intravitreal. But if you're dealing with infectious uveitis, you would need to put the patients on anti-infectives as well, along with steroids. So say you have a viral uveitis or you are operating on a patient who has had a toxoplasma, then you would want to put those patients on antivirals or antitoxoplasma a week before the surgery, and around 4 days after the initiation of the anti-infectives, you would put them on steroids as well. So that is around 3 days before the cataract surgery, you would need to be putting the patient on steroids. So before you put the patient on oral steroids, we would need to have a few basic blood investigations done. Take a physician's clearance for putting the patient on steroids, and we would put them on a relatively lower dose of steroids, and probably not around 1 milligram per kg when you would do if a patient is having an active uveitis. So probably a periocular steroid a day before the surgery. The contraindications are steroid responders, infectious uveitis, and non-glaucoma patients. And you must take a written informed consent. This is one consent we have at our organization. So I will just share a video of a posterior subtenons, which is an OPD procedure. You do it under topical anesthesia. Use a cotton-tipped applicator dipped in proparoneal. Ask the patient to look down at it. So this is the Smith and Nozick's technique of giving a posterior subtenons, and we will use a 26 gauge half-inch needle with a 0.5 to 0.75 milliliters of triamcene alone acetonide. Make sure you make side-to-side movements just to be sure that you have not engaged the glow. And then you inject the triamcene alone into the posterior subtenon space. And if it goes into the correct space, you will not have a bleb, as you see here. On the day of surgery, many of these patients will need surgery under local anesthesia. Many of these patients will be suffering from ankylosing spondylitis, so you would need to position them on table. In infectious uveitis, you might need to do a per-op tap before you go ahead with the surgery and send the aqueous sample for a PCR analysis. Preferred method is absolutely fecal emulsification, and for children, PVC with enterovitrectomy. The challenges during the surgery could be pupil management, because there could be a seclusial pupillae and a plusial pupillae or no pupil at all. The iris in these patients are very fragile and they are vascularized. Capsulorhexis could pose a challenge because the texture of the anterior capsule is altered, and you could have thick pigment clumps on the anterior capsule. It is needless to say that they need a very meticulous cortical cleanup and a posterior chamber intraocular lens implantation in the back. So you might be lucky if you just have a few posterior synechia, and then you could just use the side pole, use a spatula, and just release them. After this, you can use different kinds of pupil expanders which are available, and once a deeper exposure is there, you can go ahead with the normal cataract surgery. So you could have a patient like this where there is a totally bumped down pupil, and in these cases, it might be difficult to actually get a cleavage to initiate the synechiolisis. As you see here, there's hardly any cleavage to go ahead with the synechiolisis. But once that is done, you can use hoops. This is one of the hoops. This is a Grishaber hoops, which you can use for appropriate for exposure. Now, even if you get a cleavage plane for doing the rhexis, there might be conditions where you might have a very adherent iris onto the anterior lens capsule. So doing a synechiolisis might be difficult. Even if you're able to do a synechiolisis, those thick pigment clumps could pose a real challenge during a rhexis. As I said, the iris could be fragile, or you could have vascularized membrane at the pupil, so they tend to bleed during surgery. This was a young lady, a 20-year-old lady who had a sympathetic ophthalmia. This is the sympathizing eye, so this was the only seeing eye. And we had to go ahead with the cataract surgeon. You see there here that even pulling the iris might be difficult with these hoops as well because of inflammatory membrane at the pupil. Now your young lady, very elastic anterior capsule. We were trying to make a smaller rhexis to prevent an Argentinian flat sign. And you can see those pigments on the anterior lens capsule, so we're trying to initiate a flap to go ahead with the rhexis. And once that flap is initiated, you do a normal CCC and then a normal cataract surgery. She had a glaucoma as well, so I had to go ahead with a clear corneal incision. So once the rhexis gets done, I use a 2.8 mm keratome, a normal hydro, and go ahead with the phaco. The only breather in these uveitic cataracts is most of them are pretty soft, so nucleus management is not all that a challenge. And you see here last bit of cortex coming up. And then it is always good to use a hydrophobic acrylic IOL. So this is an Acrosoft single piece lens going into the back. And it's always a good idea to lift up the lens and wash out all the viscoelastic behind the lens. Hydrate the coats. You remove the roots one by one, and that's how it is at the end of surgery. So the post-operative medications might have to be more aggressive as compared to normal cataract, so you would need a more intensive topical steroids, either in the form of prednisolone acetate or fluorometholone acetate. You need to use cyclic agents in the form of hobitropin. Cyclopentolate is an absolute no-no because it's uveitigenic. You would need to put the patient on topical antibiotics, taper the oral steroids which the patient has been having from before surgery, and you would need to top it up with topical non-steroidal anti-inflammatory drugs as well. The post-op follow-ups could be on day 1 or week after surgery, and the final checkup in around 3 weeks' time. I thank you for your patient hearing.
Thank you, sir, for the very nice presentation. Any questions from the audience? Any questions?
Sir, as you have said that there should not be any cells. If even flare is there, you can operate.
Yes.
This is one statement from your presentation.
Right.
First statement you have said that you should wait for 3 months before going to operate uveitic cataract.
Right.
Which one is more correct?
No, the thing is, because during the course of uveitis is very unpredictable. So you may have a patient on whom you have planned a surgery, and we normally see a patient around 1 or 2 days before surgery. So many of them may have, when you have planned the surgery, the patient may not be having an active uveitis, but they might have had another reactivation in between. So what I wanted to say is, during your course of treatment, when you have decided to do a cataract surgery, the eye should have been quiet for 3 months at least. And just before the surgery, when you see your patient, if there are cells, please defer the surgery. So unless the eye is, if there are no cells, then you should do it.
Even we have read this line since very beginning that 3 months is a deferred period for uveitic. Is there any scientific basis for this? Is there any evidence-based thing that in waiting 12 weeks, the eye is going to be quiet and there is no revision in future?
Yeah. I think there are quite a lot of...
Or it is just a random 3 months we can get?
No, I think it is evidence-based. I cannot give you the references offhand, but I think there are studies which have shown that you should have an inflammation-free period for at least around 3 months before you operate.
Amitabh, there are few literatures which says you can wait for 2 months instead of 3, and the results are more or less the same.
Yeah, I agree, sir, but the only thing is there are certain conditions where you might not be able to wait for 3 months. Because if a patient has had an intraocular cataract or it's beyond that, then, but those are fire-fighting measures.
What I have found in the literature that they have done the iris angiography in uveitic cases, subsequently 4 weeks, 6 weeks, 8 weeks and 12 weeks, and they found that iris aqueous barrier is more stable after 3 months. Probably this could be the reason, that's why you should wait for 3 months.
That's the reason that even if you don't have cell, but you can still have flare that doesn't contraindicate.
Okay, thank you very much for the
Just one question. Any pre-operative regimen?
Yeah,
Pre-operative on
so
oral
as I said, if you're putting the patient on oral steroids, probably it will be a lesser dose, say around 40 milligrams per day. You start 3 days before the surgery, you omit on the day of surgery, and then you continue it post-surgery. So a weekly taper. But that again would depend upon how much post-operative inflammation you have.
Sir, we saw in your video you are having a beautiful staining of the capsule. So are you doing injecting visco, doing the stretching of the...
That's right. So I think once you inject visco, it will not get stained to hollow. So that's the reason why if you have a patient who has had it totally bound up to people, there are patients where you will not be able to see a pupil at all. So then making a nick because you're scared of injecting a viscoelastic because it might not stain. Well, I am not very confident without staining a...
How did you achieve in that sympathetic?
How did you achieve that very good staining in that?
I did not put visco before putting the...
How did you stain the skin with the iris?
So those were the iris hooks. They are the sharper hooks, but there are various other expanders available. You can have the tubulins. You have various rings
to
available.
put the expander, you have to put the viscoelastic, right? Without putting. Just.
Actually, what he's asking is that in iris hooks, putting iris hooks, you are not using visco. Okay, what I do is I do put visco, but then I wash it thoroughly and then I stain.
I think that's an
बाद में अब जो रह जाता है हम लोग आइरिस डिपॉजिटर से प्रेस कर देते हैं हो जाता है आप हाँ करते हैं हो जाता है इसलिए अब चलिए नेक्स्ट तब खाना खत्म हो
Okay, we'll go on to the next session. We are very grateful to Dr. Amitabh who has traveled from all the way from Calcutta. Thank you, Amitabh. I'd like to thank Dr. Vivek and Dr. Amitabh Singh for chairing this session. I'd like to call Dr. Subhash Prasad, Dr. Ranjan Roy, Dr. Rashmika, Dr. Pranav Ranjan, Dr. Pranav Ranjan sir, Dr. Subhash Prasad, Dr. Ranjan Ran, please come on the chair.
One nicely.
इधर ही बुला के Dr. Rashmika, Dr. Praveen Kumar, Dr. Krishna Kumar, Dr. Raj Nandini.
So good afternoon everyone.
We are giving the
Hello, good afternoon everyone. So my topic of presentation today is management of contractive juvenile idiopathic arthritis. So basically juvenile idiopathic arthritis is not a single disease but a group of arthritis occurring below the 16 years of age, and it is the most common cause of arthritis in pediatric population, and it is the most common systemic disease to cause uveitis in children, and mostly the oligoarticular type of GI. The peak incidence of uveitis is generally graceful and and girls are more commonly but 3 times more than the boys, and it mainly cause chronic development period uveitis and have poor prognosis compared to other pediatric uveitis because it causes persistent chronic inflammation, leads to formation of cataract, lymphomas, etc. And the poor prognostic factors are male patient, young at the diagnosis, short interval between arthritis and uveitis, severity of uveitis at onset, and DNA positivity. Coming to clinical presentation, most of the GI uveitis present silently, therefore detected late in the disease progression. So most of the children present to the ophthalmologist with complications like band separative posterior synetia, cataract and lymphoma that leads to vision loss. And cataract is the most common cause of vision loss in case of uveitis, and it's mainly found due to the disease process like persistent chronic inflammation and long-term use of the corticosteroid. And cataract can vary from the simple PhD effect with polychromatic lenses to total wide cataract. And this is a clinical photograph of GI patient. On the left side, so band separative with total posterior synetia, with total cataract, and region of the left eye. So secretly on the right side on the upper side, and the iris open on lower side. So coming to management of cataract start much before diagnosed cataract surgery in case of uveitis, and it is mainly related to the preoperative, intraoperative and the postoperative. So in preoperative, we have typical anterior segment examination to look for band separatopathy, posterior synetia, total cataract and disease activity. And 3 months inflammation-free period is mandatory for doing any type of uveitic cataract surgery. And longer the inflammation-free period, better is the postoperative outcome in case of GI uveitis. And adequate perioperative steroid and immunosuppressive cover should be given to minimize the postoperative inflammation. And in cases with total cataract, there the and the posterior segment examination cannot be done. Ultrasonography should be done to look for the choroidal vitritis and the retinal detachment. In cases where media is clear enough to capture the image, also test can be done to rule out the macular edema. And the most important is the counseling of the parent. Parents should be informed about the visual prognosis, visual outcome, and the complication of the surgery, and the surgery may last longer than the usual time in cases of pediatric cataract. So coming to the intraoperative, so cataract extraction is not a major issue in any type of pediatric cataract. Major challenges is pupillary management, how to manage the pupil during the surgery, capsular management, and whether to implant IOL or not. So coming to pupillary management, the recurrent size of pupil is required in any type of cataract surgery, which can be achieved in case of uveitis by viscomedrasis or by pupillorexis. Pupillorexis is nothing but just peeling of the membrane from the pupillary margin. And next one is the sphincterotomy. You can achieve the recurrent size of pupil just by giving the relaxing incision near the pupil. And you can achieve the recurrent size of pupil by using your pupil expander like iris probe, rings, or by the pupillary tubes. And this is a short video clip. So how to implant the iris probe in case of uveitic cataract? So for paracentesis in 3 periods, 1 mm behind the limbus. Then iris probe is inserted in the anterior chamber and hooked from the pupillary margin. So coming to capsular management, so capsular cataracts are soft and friable and can easily run worse than the general pediatric cataract surgery. So always do anterior capsular access under the after staining with trapezoidal and always do under the heavy viscous anesthetic and always use forces for better control compared to the total. In some cases you can get fibrosis, that's okay. In those cases you have to do anterior capsular access with the use of MBR knives and scissors. So this is the surgical video. In this case you can see there is a fibrosed capsule. So I was not able to do the capsular access with normal forces. So I did entire opening with the use of intravitreal 23 gauge scissors. So coming to cataract, the cataracts are very soft, so can be easily removed. But keep in mind about the lower, because most of the GI uveitis cause chronic type of uveitis, which causes very symptom. So most of the patients may have lower IOP, so manage accordingly. And most of the patients may have weak joints, so don't manipulate too much during the posterior synechia removal and during the cortical cleanup. And in some cases, CTR slowly may be required for better centration of the eye. And most important is the cortical cleanup. So in every case, thorough cortical wash would be given to minimize the post-operative inflammation and the fibrosis. Coming to posterior capsular access, in all cases of pediatric cataract, posterior capsular access must be done till 8 years of age to minimize the posterior DOA, and anterior vitrectomy should be done till 5 years of age. IOP should be implanted in all babies above the 2 years of age with good preoperative control of inflammation and must be implanted in the capsular bed. And most of the patients do well with the acrylic type of IOP compared to the other type of IOP. So this is a short surgical video clip of complicated cataract. So anterior capsular access is done after staining with the trapezoidal dye under the heavy viscoelastic. And then hydrodissection is done in multiple quadrants for better nucleus cleavage. The nucleus better is aspirated with the help of biomedical instrument. And then complete cortical cleanup was done, and then posterior capsular access was done using the 23 gauge lamp forceps. and then anterior vitrectomy done all around 360 degrees. Till the edge of the posterior capsule hangs behind. So these are the stages regarding comparing the implantation of IOL in GI and all GI patients who well with intraocular implantation of IOL in the back with good preoperative control of inflammation. So coming to post-operative period, during post-operative period we have to monitor the inflammation because most of the patients have excessive inflammation after the cataract surgery. So manage accordingly with increasing the topical and the oral support. Most of the patients have higher IOP target in the intraocular pressure because of the excessive inflammation is already compromised by the muscle. So manage accordingly. And this is the late complication of any type of cataract surgery, and it is more in case of the erratic type of cataract surgery. And you can see here that this is the post-operative picture of the patient showing anterior VOA, and the medium of the same patient showing iris bounding with a trachea. And this was managed surgically. And this is the intraoperative after the surgery showing clear media. This is the photograph of the other patient showing posterior.
Be fast.
Then this is the intraoperative picture of the other patient showing posterior VOA, which was managed which is past plan membranectomy. And this is the clear media after the past plan membranectomy. And in cases with persistent chronic inflammation, you can find cystoid macular edema and the steroid immunosuppressive. And the steroid immunosuppressive covers will continue in the post-operative period. So to summarize, pediatric cataract needs a special attention. It is not just like any other cataract surgery. And the long inflammation period is must for doing any type of pediatric cataract surgery. At least 3 months, and a record period of steroid immunosuppressive covers should be given for minimal post-operative inflammation. And the pupil and temporal management is a crucial part in the management of any type of pediatric cataract surgery. And of course, it is the pediatric cataract surgery. The measures should be given wherever required. Thank you.
Thank you. I will like to invite the next speaker. Due to paucity of time, we cannot have question and answer. Same thing was discussed in the last talk. And I will request the next speakers to please curtail your presentation by 2 minutes at least, in interest of. अच्छा ठीक है 3 मिनट. कौन है? Who is presenting? Dr. Satprakash.
Dr. Gyan Ma'am. बोलने को बच्चा
he can think out the box. So he can.
Good afternoon, everyone. Thank you, Sabri sir, and local organic team, Bihar Society, for a wonderful clear arrangement, and especially CSC. So this is for giving the opportunity to talk on the topic uveitic cataract. Most of the things is covered by previous speaker, Dr. Vital and others. I would like to highlight some salient points. When we see a cataract in uveitic patient, don't take it easy because it gives lots of problems in the post-op period. So we have to careful evaluation is very important, and proper management is very So particularly in the management of the uveitic cataract, course of the disease, management, complication and visual outcome are directly related to the types and course of the uveitis, and proper management is very important for uveitis and its etiological factor for prognosis of the cataract management. Generally, we face difficulties in the management like post-op process of the disease and existence of underlying pathology, poor tolerance to the IOL. Sometimes the eye becomes dead. And intraoperative challenges are already discussed, poor posterior synechial pass, small pupil, vasculofibrinosis. Sometimes we face bleeding during the surgery and neovascularization if not done on preoperative then sometimes bleeding occur or hypothermia may occur post-operatively in the case of uveitic cases. What are the, basically we do the surgery particularly in the echo antigenic uveitic cases, or if the significant cataract and patient with a good expected visual potential, when eye is properly controlled, then we can go for the cataract surgery. And cataract surgery can be done for the posterior segment assessment. We think for the disease in the posterior segment, so we can do the cataract surgery. And most important thing is the when to do the surgery. Previously we already discussed about the at least 3 months eyes should be quiet before to the surgery. And before going to the surgery, preoperatively aspirin or anti-inflammatory medicine can be given. In case of the pediatric cases, if we want to prevent amblyopia and posterior segment devaluation, then we can go for the cartilage surgery in the earliest stages. What should be done early, because there is a mature cataract and may interfere with the timely detection of the posterior segment complication, then we can go for the early cataract surgery. If there is an advanced cataract, particularly in the older age, if we become harder, then it will be very difficult, so we can go for the early cataract surgery. These are the complications, co-competent pathology can occur during the surgery, so careful evaluation is mandatory. Ultrasonography and other posterior segment examination is needed, because after the uveitic cases we do the good surgery, but post we cannot regain the proper vision due to the macular pathology and other lesions. Evaluating the risk factor, eye with poorly controlled uveitis at high risk of severe post-operative inflammation and hypertonic. Even crisis may occur in the post of surgery. So, if we get a poor IOP control, occlusively or in the normal eye, or apparent phacodomus without evidence of lysis, and difficulties diffuse thickened choroidal and choroidal diffusion is a poor prognosis should be explained to the patient. Pre-operative management, first infection and treatable cause of uveitis must be identified, and treatable cause of toxoplasmosis, TB, syphilis should be taken care before going to the surgical procedure, and systemic causes of uveitis must be identified and treated pre-operatively. And these are the surgical procedures we can do on the surgery, and these are the devices we can use intraoperatively, already discussed by Dr. Amitabh. And here I am going to what were the type of IOL and where we can place the posterior chamfer implantation was very proper site, avoid anterior SIOL and avoid sulcus implantation, and eyes should be single piece IOL or hydrophilic. If heparin coated IOL available, then it should be advised. Here I am going to show a case, the older group with the synechial harder cataract by management by the small incision cataract surgery without any advanced devices or machine. We can also manage such cases by the small incision cataract surgery after vital suture given for the superior rectus muscle and peritomy of the conjunctiva. Incision was made at the just below the limbus, and tunnel was made with the crescent blade. So looking cataract was harder, so we made a little bit larger tunnel in the scalpa, the skull canal tunnel, side cords are made, and after the making the side cord, we tried to release the pupillary membrane or synechia. Some portion was released, but some portion was not dead. So it is trying to live with the iris deposition. Still there was a membrane attached to the pupillary margin, so we decided to enter the embracement with the catone plate and try to pull the but it is normally either with the margin, then it was cut with the Manas cedar, the membrane. Because we have again we try to make spectrometry by dilating the people with the two instruments, wide dialer and dialer, so that we can have a little bit larger pupillary area. Already viscoelastic material properly washed with the cannula, then after we inject the pupil glue so that entire capsule can stand properly. With washing the saline glue, pupil glue with the saline and remaining air bubbles and stem. So you see here the capsule was properly stem, and we try to keep a little bit larger capsule vaccine. So capsule vaccine margin was not visible properly, but it is smooth and rounding circular. So try to capsule vaccine in properly, and we achieve the capsule vaccine, and hydrodissection was done in the multiple place with a small pill so that the nodules cannot damage, and nucleus rotation was done with the dialer. Nucleus was properly rotated. Then after, with the help of the two instruments, one is dialer and other is the iris depositor, we try to bring out the one portion of the nucleus above, and we achieve properly. Then with the help of the irrigating vacuum, nucleus was removed in total, and the entire chamber was washed with the IA cannula, in which we try to always keep the cannula in horizontal manner, not go beyond, because people are so small. There was more GP cortex, and so after cleaning the entire cortex, we implanted sir, we can receive IVL. Just to see here, we try to implant the lens with your middle lens in the back. Then after cortical cleaning was done properly and wound was repaired. In spite of good surgical procedure, we can have such type of complication may occur. So conclude that thorough assessment is must. Disease should be researched before for 3 months before going to the surgical procedure. Proper surgical technique, choice of IVL, post-operative control of inflammation and complication can lead to the satisfactory visual outcome of the cataract surgery and prevention of the uveitis in normal cases. Thank you so much, sir.
थैंक यू डॉक्टर भास्कर। फेको क्यों नहीं किया भाई? फेको इमल्सिफिकेशन क्यों नहीं किया?
Sir, two reasons था sir. One is the nucleus seemed to be harder, and pupil was iris margin was explored and pupil was floppy. So we decided to safer method, because we are not assured about the zonule, but the condition of zonule, so that we decided at least remove the nucleus properly, so patient don't have the post-operative complications.
It's always debatable. It depends on the situations and expertise. For me, I never try SICC. I always go for PECO, but anyone who thinks that he may encounter any problem which is compromising the patient's outcome, it should be done in that way.
Yeah, you have done the right way. But one just quick question: which causes more inflammation, SICS or PECO?
So basically, it is depend upon the pre-existing condition. If we did the SICS properly, it also causes less inflammation. Therefore, if intraoperative complication, any surgery, SICS of PECO can lead post-operative more inflammation.
Your surgical time, sir.
I think
in
it's
this case.
very.
SICS can be done in 5 minutes. PECO will take 10 minutes. Time all the time.
I think there's no doubt that Mako is the preferred. And with the newer machines available, I think you can do Mako even in the hardest.
So SICs will definitely cause more inflammation because the amount of iris manipulation is much more.
Dr. Satya Prakash Tiwari, renowned vitreoretinal surgeon of Bihar. And though he is vitreoretinal, but he is now doing all those things what we all are doing.
Thank you sir, thank you for the kind introduction. ये टॉक के लिए सत्यजीत सर को धन्यवाद। सर बोलेंगे कि तुम अपना टॉक भेजो, तो हम बोले सर क्या बोले, तो बोले तुम कुछ ऐसा बोलो जब वीआईटी से स्टेरॉइड से इम्यूनोसप्रेसिव से भी नहीं ठीक हो तब क्या करेंगे। तो हम बोले चलिए ठीक है। इट्स अ लास्ट टॉपिक। रिसेंटली आई अटेंडेड वन होल डे कॉन्फ्रेंस ऑन जस्ट बायोलॉजिक्स इन वीआईटीज. दिस इज अ ह्यूज चैप्टर, बट आई वुड लाइक टू point out on just 2-3 important slides which we also keep in mind whenever we are planning or advising a patient about these biosimilars. So we all know that intraocular inflammation is becoming a very common cause of loss of vision in entire developed as well as developing world. The broad classification is infectious and non-infectious uveitis as far as the treatment is concerned. If it is infectious uveitis, we have to control the inflammation and treat the infection with anti-infective agent. If it is inflammatory or idiopathic or some autoimmune thing, then we have to treat it with steroids. If not responding, then steroid along with immunosuppressive. And if nothing is working, then the last sort of treatment comes is biologics. So why biologics? We all know that pathogenesis and pathophysiology of uveitis involves inflammation, and this inflammation involves role of cytokines, and this role of cytokines in pathogenesis of uveitis has been established beyond doubt. All the cytokines supposed to be raised, and it has been proven by doing vitreous tap, AC tap, and then analysis of that fluid from vitreous and AC suggests that cytokines are elevated and they are triggering inflammation. This is a chart, that article published in Indian Journal of Ophthalmology by the group of Dr. Rupesh Agrawal, and it shows the different inflammatory marker raised in different types of uveitis, like interleukin-1 in sarcoidosis and intermediate uveitis, interleukin-2 in idiopathic uveitis or Behçet's, Fuchs, heterochromic cyclitis, ankylosing spondylitis, and interleukin-6 in especially in VKH sarcoidosis. Then interleukin-8, TNF-alpha, interleukin-T and TGF-beta. All these inflammatory markers are found to be raised in uveitis. So what are biologics? Now we have established that these inflammatory markers are causing inflammation and uveitis. So what are biologics? Why we are targeting all these inflammatory markers to be treated by biologics? Biologics we are using a lot in vitreoretina, especially all these monoclonal antibody anti-VEGF molecules are biologics. So these inflammatory control biologics are also similar kind of things. They are bioengineered molecule produced by living organism, and they target cellular receptor or cytokine responsible for inflammation. They are alternative in cases of inadequate response or there is intolerance to conventional therapy like immunosuppressive or steroids, and they may be first-line therapy in certain conditions of aggressive uveitis also. Biologics are also nowadays available as original innovator biologics as well as biosimilar to biologics. As we all know that in vitreoretina ranibizumab is available, then ranibizumab biosimilars, then aflibercept, biosimilar of aflibercept, then bevacizumab, biosimilar of bevacizumab. Similarly, in anti-uveitic biologics, there are a lot of biosimilars are also available which work well, but there is definitely some sort of difference in between these two. This is elaborative chart which shows that different stages of inflammation in uveitis and where we can attack with what type of that anti-inflammatory agent. There is a naive T cell and then there is antigen presenting cell, and these cells stimulate and T cell becomes activated T cell, then that generates immune response, And for every response, we have different sort of agents like eptabarcept, then rituximab, then we come to interleukin-6 or interleukin-1R, then interleukin-1R is Enkinra, interleukin IL-6 is tocilizumab. This tocilizumab drug was very popular during COVID time, and whenever there used to be a massive cytokine storm with raised interleukin-6, the physicians used to give tocilizumab, although the role was debatable. And then coming to this inflammatory stages, we use lot of anti-TNF alpha inhibitors like infliximab, adalimumab, golimumab, then certolizumab, etanercept, and all these MAB drugs ending with MAB are basically monoclonal antibody, and this etanercept is a fusion protein. So this is different a little bit, rest all are monoclonal antibody. And at the same stage, our corticosteroid and immunosuppressive also does work. So the most important biologic we are generally practicing and using is anti-TNF alpha inhibitor, and it has a lot of classification. The first generation included etanercept, that was a recombinant fusion protein, then infliximab, adalimumab. The second generation has certolizumab and golimumab. Then came to daclizumab, Enkinra, and givokimumab, tocilizumab, secukinumab, and rituximab. All these are very difficult names, many a time difficult to pronounce and remember as well. But then many interferons have also been tried and to be used. This is a chart published, again an article published from IGO. This chart shows the dose, how to give, and possible side effects of different commonly used biologics. This is differentiation of certain different biologics used commonly are rituximab. I will not go into the detail of this rituximab. Adverse effect, then eptabarcept. Let me skip all these details of different individual these MABs like infliximab and adalimumab. These are the two most commonly used biologics, and I wanted to highlight only these two drugs. This adalimumab, Humira, I think in India only biosimilars of adalimumab are available, not the original innovator, and it is being marketed by Reliance. Reliance is investing huge on all the biologics, and in coming market of pharmacology, all the biologics market would be captured by Reliance, I think. So this is approved subcutaneous injection. It is used in early management of patients with vision-threatening ocular manifestation of Behçet disease. The second line in additional immunotherapy for children in JIA, and second line immunomodulator therapy in patients with vision-threatening seronegative spondyloarthropathy. This is article published, and this is case from by the group of Jyotirmay Viswasa present in published in IGO. The role of adalimumab before injection and then after injection, the uveitis resolved. Again, a case of Blau syndrome with infliximab and adalimumab. Dr. Parthopratim was presenting also. Then came to golimumab, certolizumab. All these are uncommon drugs, not much used. We are using two commonly used drugs. These are adalimumab and infliximab. And adalimumab is having superior efficacy, better safety, higher remission rate, and better tolerated drug. So generally it is used more commonly over the infliximab. Lot of side effects are there, but two most important side effects or contraindications, what we can say, we must remember that these drugs are highly toxic drugs. They can flare up any kind of silent disease present in the body, just like some small or undetected malignancy or tuberculosis in remission. So in these cases, if we start biologics, they may lead to flare up of tuberculosis and a spread of malignancy. So always be very, very careful before starting or even suggesting, and there must be thorough checkup by a physician or internist to rule out any underlying disease in the body in any part. Then only we suggest, and it is better to keep in loop a rheumatologist. Generally, as far as I am concerned, I am never advising or injecting my own. Whenever I am suggesting, I am sending my patient to a rheumatologist. they are well versed with using these drugs and they are giving the drug, and then patient is coming to me for follow-up, and we do see the effect if the drug is working or not, and rest of the part like effect, side effect and everything is being taken care by rheumatologist. So this point I just wanted to highlight in this whole presentation before starting biologics. Clinical examination to rule out any previous cardiac disease, malignancy, neurological disorders and any silent infection. Patient must know the red flags of adverse effect with the use of biologics. Patient should be advised to see a doctor if he develops a fever, sore throat or bleeding. Laboratory investigation, all these things are extremely mandatory before we start giving biologics. So this was all about, in short, biologics. Thank you so much to all of you for having this patient hearing. Thank you so much.
Thank you, Dr. Tiwari and Dr. Amitabh. I think just we had a discussion regarding pediatric cataract surgery. What is the incidence of cystoid macular edema in uveitic pediatric cataract cases? Is there any difference between adult cases versus pediatric cases, and how do you treat it?
Yeah,
This question is for both of you, retina and uvea.
Yeah, I think the chances of post-operative inflammation is much more in children because their immune system is very strong. Anyways, you would have operated on that patient as the inflammation would have been under control. But I think the most important things are to methotrexate is a very good option pre-operative, along with steroids. And in these patients, we don't usually use periocular steroids because of the high chances of steroid response. And the other thing is, once you have given it into the posterior subclavian space, it is very difficult to, you cannot undo it. The chances of, if it is a properly controlled uveitis, then normally you should not be having a lot of cystoid macular edema. In adults, it's around 0.1 to 2.35% in a normal cataract. But there are various reports which say that in uveitic cataracts, the chances of CME they range from around 12% in a week's time to around 8% in around 4 to 6 weeks' time to around 6% further down the line. So, but definitely in pediatric cataracts, the chances of post-operative inflammation and cystoid macular edema will be much more than adults.
As far as I am concerned about pediatric post-op CME, we have to look for two things. For any CME post-cataract surgery, inflammation is the basic thing which happens leading to CME. So in pediatric GIA-related cataract uveitis, we have to see if this inflammation is due to primary disease or this is due to misplacement of IOL. Many a times IOL is also misplaced in pediatric GIA cataract. So if it is a primary disease and inflammation, then we will see a lot of things, cells in the anterior chamber, then maybe there may be some vitritis and then uveitis kind of feature. In those cases, we have to control the disease, treat the GIA with methotrexate or if needed biologics or whatever. If we see that IOL is misplaced, then we have to think about explanting the IOL if it is not in the bag, if a strong thick heptic is in the sulcus or something like that. If it is disturbing, then many a times we have to explant the IOL, do a proper interior vitrectomy, make the eye free of any external agent that is causing and instigating inflammation and leading to CME. If we control all these inflammation, then there is very less likelihood of getting CME in post-GIA cataract.
Thank you. Dr. Satyajit.
Thank you so much all speakers and panelists. Thank you Dr. Rajgir. Thank you Dr. Rajendra. Thanks. So same topic. So we'll break for lunch now. How many people have had?
Five tips at least. Give 5 tips on how to manage a cataract with uveitis from your side. Out of box tips. That will complete your presentation.
All the things that have already been presented, that 3 months there should be no inflammation, so on and so forth. The cells and the flares will not.
Thank you, Satyajit. Thank you.
Everything has already been covered. How many people have had lunch?
There is one question from my side to Amitabh also. What is the role of doing peripheral iridectomy in pediatric patient who had this JRA associated cataract?
Sir, I don't have a lot of experience with pediatric cataract because that is in our institution that is done by a pediatric hospital. but normally I do get to see those post-operative patients, but I have not come across any pediatric uveitic cataract which has had a PI done, either a surgical or a...
Okay, can we please call the next set of co-chairman and chairman? Thank you very much, sir. Thank you for your time and contribution. Dr. Pradeep Karak, sir. Dr. Ravi Ranjan. Dr. Abhishek Anand. Dr. Shalal Sinha. Can you please come on the chair, please? Dr. Rajnish Kumar. Dr. Swati Singh. Dr. Akansha Rani. Dr. Sunila Kumari. Okay, so can I request Dr. Ranjana to please come on the chair? And can I request Dr. Amitabh to please come on the chair, please?
Good afternoon, everyone. First talk is by Dr. Ravi Ranjan, cataract surgery, its effect on the lacrimal drainage system.
Very good afternoon on the dais, on delegates in front of us. My topic for today is cataract surgery. Let's go back. Cataract surgery, its effect on lacrimal drainage system. On the outset, I want to define lacrimation is defined as sign of overflow of tears and may be caused by hypersecretion secondary to ocular inflammation, conjunctival and corneal surface diseases, trauma including surgical trauma to the conjunctiva and cornea, and epiphora is defined as defective drainage due to compromised lacrimal drainage system, secondary to malposition of lacrimal puncta, obstruction along with lacrimal drainage system or lacrimal pocillia. In usual OPD, one of the most common complaints by post-surgical cataract patients, both from whether it is phacoemulsification or SICS, डॉक्टर साहब पानी गिर रहा और लगता है आंख में कुछ पड़ गया, लग रहा है कि कहीं कुछ घूम रहा, and etc. etc. It is a very common complaint by patients. Sometimes patients say कि डॉक्टर साहब जो लेंस लगा है कहीं माथा में तो नहीं चला गया, घूम रहा है, गड़ रहा है, and lot of things. And the objective of this study is to determine the effects of cataract surgery on the lacrimal drainage system in eyes with age-related cataract. And this is completely observational study and was performed on 200 eyes of 200 patients with age-related cataract. Among the patients, 104 patients were male, 96 were female. And all the patients were from agriculture and a mixed class of a small town, because I belong to a very small town that is Vikramganj in Rohtas. And the patients were equally divided into two groups, 100 for phacoemulsification and 100 on SICS with PCIOL implanted in one eye. And the average age of the patient were ranging from 51 to 80 years. And all the patients were operated under peribulbar anesthesia. The included patient had fluorescent disappearance test, FTT and taste test of roughly 6 minutes in both eyes before operation. And tear drainage function tests were repeated for 1 week and 1 month after surgery in both eyes, and data were obtained. And the incidence of watering eye with phacoemulsification surgery in eye treated for age-related cataract was roughly 17% at the end of first week and 9% after 1 month. And after SICS, the incidence of lacrimal drainage impairment was 19% at the end of first week and 12% after 1 month. A very jaw-dropping finding I have got, and it's observational study. It was found that more than 67 to roughly 70% of the eyes have positive corneal staining. 60% have tear film breakup time less than 5 seconds, and 21% have Sherman scores of less than 5 mm. And the majority of patients did not report symptoms that are suggestive of dry eye. And however, more number of elderly patients develop watering eyes than the lower eyes group,
Among the patients from 71 to 80 years age group, 15 patients developed watering eyes. And there was slight difference between male and female in clearing after operation. Out of 104 male, 19 patients approximately, that is 18.26% were absorbed watering eyes in the first week follow-up. And among female patients, 17 patients complained of watering in the first week follow-up. And in my study, no difference of watering was absorbed in respect of socio-economic conditions. And no post-op complaint of watering was absorbed in sound eye, that is other. When you come to this discussion, the causes may be decreased drainage or increased secretion of tear or combined mechanism may be considered the etiology of the symptom. And the inflammation of the ocular surface and radial segment of the operated eye could extend into lacrimal drainage system and cause functional impairment of lacrimal drainage and secondly acquired lacrimal drainage obstruction. And surgical trauma, subconjunctival injections, especially preparation of eyelids and conjunctiva with providing solution, because providing is known irritant to the FD mucus layer. Before surgery could affect the extent of ocular inflammation through leakage of providing solution into the drainage system, the lacrimal system. And the functional impairment of lacrimal drainage in old age as a predisposing factor in this regard. And the corneal incision made at the time of surgery disrupts the feedback mechanism that stimulates the lacrimal gland by the corneal nerves. That may be the cause of the excessive or tearing. And prolonged exposure to the microscopic light, aggressive irrigation of the tear film, and frequent topical anesthesia on the day of surgery all traumatize the corneal epithelium and or cause conjunctival mucous goblet cell loss. And the less forceful blinking by the patient in the early post-operative period might cause weakness of the lacrimal pump that could stimulate a functional occlusion in the already compromised lacrimal system of the old age because due to deep visualization within the lacrimal drainage system and higher incidence of primary acquired major lacrimal duct obstruction in individual age 50 to 70. And it is a very common finding in patients just बड़ी सावधानी से आंख बंद करता है कि हमको ऑपरेशन कराया गया है। सत्यजीत तुम जब सो रहे हो। Complaining of watering eyes are a bit more essential than phagoemulsification surgery can be explained by the fact that this group of patients develop more reflex lacrimation due to conjunctival and limbal incision injury. And improvement of watering 1 month post-operation in comparison to 1 week post-operation indicates that the effect of predisposing factor has gradually decreased. And however, more number of elderly patients develop watering eyes than the lower age group due to already compromised lacrimal drainage system in old age, already I have told it, and slight difference in watering after cataract surgery was observed among male and female patients. And in addition to the pre-existing dry eye, cataract surgery may evoke the ocular surface of an asymptomatic dry eye symptomatic. And the etiology is multifactorial. And in conclusion, I can say अरे पीछे नहीं जा रहा जाएगा अरे देखो पीछे नहीं जा रहा आ गया
फोटो देखा अवार्ड लेते हुए अब जानबूझ के हम लोग को बार बार देखना चाहते हैं
नहीं जाता and in conclusion and in conclusion, the result of this study indicate that watering eyes may develop in some patients after cataract surgery for age-related cataract, irrespective of method of surgical procedure, and male or female can be affected with an increased incidence of among female and elderly patients. इसको बंद करो हाँ या and thank you for patience listening. Thank you.
Thank you, Dr. Ravindran sir. I would like to ask, you have not elaborated on the which drops do you use pre-operatively and post-operatively, because if you are prescribing any tear substitute pre-operatively and continuing it in the post-operative period, the chances of patient having watering or the dry eye related symptoms is less. And also sometimes the medication that you use, the prednisolone itself, the particles, they cause more irritation. And in contrast, if you use dexamethasone, the particle size is less, so it doesn't irritate as much. So I wanted to know what are the drugs you use pre-op and post-op, and how do you document the tear breakup time? Do you have a machine that takes the tear breakup time, or you just stay
on sleep time? On sleep time. That is a rough estimation. That's why I have roughly 6 minutes.
6 minutes?
Yeah, 6 seconds.
So what do you use in the pre and post medication?
What medication? Everybody uses moxifloxacin eye drop before operations, and prednisolone, naxisolone, moxifloxacin combination post-operative.
No tear substitute?
Yeah.
You don't use any tear substitutes?
No, post-operative for 1 week, no tear substitute. After that, I am.
So I think, what is the general consensus amongst all present here? How many of you use tear substitutes pre-operatively?
Pre-operatively, why tear substitutes? If patient is not complicated, not complaining anything, why you will use tear substitute? Because that's why I have got. In 67% I have got feature of tear breakup time is here. And they are not complaining of.
One of your slides said that most of these patients are asymptomatic dry eye patients.
Yeah.
Asymptomatic.
Yeah.
You know that in the post-operative period, this patient is prone for developing dry eye. So isn't it a wise decision to use tear substitutes also in the pre-operative period and continuing it in the post-operative period? So pre-op nobody uses? No.
Apart from the science, we have like businessmen in our setup. Patients are telling कि पहले ही से इतना दवा डाल रहे हैं, वो और दवा 400 रुपया का दे दिए, तो फिर अब हम कितना दवा डाल दे रहे हैं?
पता नहीं।
ऑपरेशन का भी पैसा आप ले ही लिए, उसके बाद 4000 का दवाई में डलवा दीजिएगा।
The service is good. If the service is good, then free of tear substitute is not required usually. At least in our part of the world, hardly people use tear substitute before surgery. But if the surface is not good, obviously you stabilize the surface, give tear substitute. And then once it is good, then you go ahead with the surgery.
He is saying that you are anyway anticipating some amount of dry eye post-cataract surgery. Would the outcome would have been better if you had started using tear substitute from before cataract surgery?
So that's what I tried to come to, because in my practice I used to see a lot of patients post-operatively complaining, sir, kuch gad raha hai, kuch raha hai, kuch ye ho raha hai, wo ho raha hai. From the time I started using one particular tear substitute, the incidence of watering and foreign body sensation has come down drastically. Fewer and fewer patients now complain of foreign body sensation or watering because I give pre-operatively tear substitutes in all my patients.
So did you do a comparative analysis by not giving a group of patients these
No, I'm not doing a comparative.
Our patients were asymptomatic pre-operative.
No, I'm not an analysis, it's just a clinical observation.
Maybe you should stop and see, because you're giving it post-operatively, no?
Yes.
When you're giving it post-operatively, obviously the breaking will be less.
Yeah, but I start beforehand so that ये नहीं होता है कि जो सर बोल रहे हैं कि 400 रुपए का फिर से दवाई लिख दिया।
बहुत कंप्लेंट करता है कि 400 रुपए का पहले ही दे दिया, तब फिर आगे कितना
ठीक है सर। Thank you sir. We come to the next talk, which is tackling premature cataract. Which will be presented by Dr. Rajgir Kumar and Dr. Nilesh. Are you ready?
Good afternoon, everyone.
Where's Nilesh?
This talk was meant to be for the uninitiated, but we have veterans sitting there, so I would not try not to be didactic. Mature cataract tackling white cataract. In the current scenario of continually evolving cataract surgical technology, though we've been stuck at flags for quite some time now, but most of us would agree that mature cataract presents a challenging entity for even the more experienced of the surgeons. Due to the increased surgical challenges and risk of complications, there is an increased focus on the techniques. All of us understand that a pre-surgical evaluation, a good slit lamp examination, and since you're not able to see the fundus, a E-scan ultrasonography is mandatory. You have to do a careful surgical planning. You need a wee bit of a skillful surgical technique and of course a lot of good fortune. Now facts regarding dealing with a mature cataract. The capsule ends up being more fragile. Once you nick the capsule, there's a leakage of liquefied cortex and there's an absence of red reflex which obscures your visualization. High intralenticular pressure tends to let your rexus run to the periphery. The anterior capsule may have calcified deposits that hinders your rexus. The nuclei of varying hardness may be camouflaged by the oblique cortex. You do not have a protective epinuclear cushion most of the time, and in the end, it ends up being more complicated by a residual posterior plaque. Now the challenges. The biometry is the ultimate challenge. Precise biometry remains the most fundamental requirement for optimal visual results, and a mature cataract continues to be the most confounding factor that obstructs the device wavelength and it disrupts the refractive outcome post-surgery. Optical biometry, as we all know, is a gold standard, and the current gold standard is the swept source OCT-based technology where IOL Master 700 gains. You have now Argus, you have anterior, and you have a Tomy device, and then you have an iStar 900 by Harkstreet, which are on that platform. However, despite all the technology that you might have at your disposal, you will get the results in 85% of times, even if you're using the IOL Master 700. So what is your backup plan? The backup plan is your immersion, and which continues to be the most reliable option for measuring the axial length of the eye. If you have an optical biometer, you feed in the data into it and you get your IOL bar calculation. But we do understand that once they're doing immersion and mix and match of different devices, the patient needs to be counseled well for the post-surgical refractive error. The capsular rexus challenge is the most limiting step in the successful phacoemulsification of a mature cataract. And incidence and studies do say that the incidence of incomplete rexus ranges from 3.85 to almost 28%, which is quite high by any standards. Now you have the non-intumescent challenge where the rexus proceeds as usual. There is no leakage of fluid, and you go on and you complete it as if you would in a normal cataract and proceed with the surgery. It almost behaves like a flat bread. Then you have the intumescent challenge. You nick the capsule, the fluid leak, the cortical fluid leaks, you aspirate it, and then you try to complete it with using a microrexis forceps, which could be easier in some of the cases. You just start once and you may not, and you end up continuing completing the entire rexus in one go. The second case was more challenging, and the rexus almost threatened to run every time. Trypan blue is something that I always opt for, and you can do it without staining the capsule, but I would rather spend 40 or 60 bucks into Trypan blue rather than reduce 36 days or 36 weeks of my life. So I opt for Trypan blue in almost 100% cases. No Trypan blue, no surgery. So I started this trend to run out. I'm more of a cystitome operator. I tried to shift onto the cystitome, then I realized that I was not getting a good grasp. And then I finally completed the rexus, doing it somehow. But this was a premium patient, and I had to do a phaco in this case. So the option of changing into any other method of cataract extraction did not exist for me. I thought I would make a main port and then go through there. I could not grasp it over here. And I thought, I make the main port, but then I finally completed it through the side port itself. The wall lit up technique. The next technique that you can use is start small, and as you go around, you complete it. I did not have a video as good as Dr. Deepak Megurs, so I have taken the liberty of taking bit from there. So you go, as you move 360 degrees, you continue to enlarge it. Most of the time, this is a very accomplished procedure where they've gone multiple times and increased the CCC. However, a lot of times you just do it once or twice and then you get over with it and your rexis is completed. You can just go to the double rexis method where you make a small rexis initially, then you do fluid aspiration. You can use your IA cannula, you can use Simcoe. It depends on your convenience level. And then you nick the capsule and then you enlarge it. Though I'm generally a more conservative person, I just use flush it with a Simcoe with a hydro cannula or use a Simcoe. I rarely go in with an iron. Hydrodissection is generally not required in a mature cataract case. However, because of the liquefied cortex, your nucleus tends to rotate automatically. If at all you need to do it, you just have to use small bits of fluid, and careful hydrodissection is the safest approach because you might end up being with a posterior polar cataract. The phaco technique, you need not change your phaco technique. You either do stop and chop or you direct chop, that is, do whatever you're comfortable with, but start with low parameters. You might end up doing a supracapsular phaco or a phaco in anterior chamber if you have an Argentinian flag sign, or you anticipate that there is a zonal weakness or there is a capsular damage. The posterior capsule tends to be very thin and lax, so extra care needs to be taken while you are phacoing the last piece. The rexis that I completed earlier, this was simplest of the soft cataract, and it could be accomplished in the normal way without any hazards. You could have a mature brown cataract, you have a Morgagnon cataract. That will be part 2 of the presentation when Satyajit gives me a chance in the next conference. So this is, once you complete the rexis, the rest of the job is easy. Whatever the technique, the basic is that you start with the lowest settings possible and adapt the power, flow, vacuum, bottle height as your case demands. Intraoperative complications, as most of the cases that we know that happens in cataract surgery, however incomplete capsulorhexis dominates, and a PCR rate in a lot of studies have been found to be slightly higher. If normally it is between less than 1% to 4%, in a mature cataract, almost in some studies it has gone up to 7%. Intraoperative meiosis and Spanish shaping, it's a complicated case, might happen, and you might have to end up being converting to a non-phaco technique. Post-operative, if you have done a supracapsular or an anterior chamber phaco, you end up with a lot of striate keratopathy and corneal edema, and the worst come first, the retinal pathology is diagnosed post-operatively. A B-scan might give you a retinal detachment or a staphyloma or a hemorrhage, but if it's a distinct retinal pathology, you diagnose it post-operatively and end up explaining everything to the patient why you could not tell him earlier. The take-home message, there is no homogeneity in various kinds of white cataract that you will encounter, and there is no single solution that fits all. The adaptability of a surgeon and the flexibility of his or her approach and the technique that you have will be the key to success. And your confidence and lots of good luck. Thank you.
Thank you. Thank you, Dr. Nandita, for taking us through the management of mature cataract, and very correctly pointed out that the capsulorhexis is the limiting step, the first limiting step in the management of any mature cataract, especially the intumescent cataracts. So next we have Dr. Nilesh. He'll be talking about hydro procedures beyond hydrodissection.
Thank you so much, sir. And thank you, Satyajit, sir, for giving this opportunity. And before I proceed, I would like to congratulate the MPC LOC. A new bar has been set for hospitality, and it will be difficult to cross. Thank you so much for this warm conference. As Satyajit sir had told earlier, and he is always gracious in his praise. These procedures has already been tried by surgeons that are better than me, and this is just a good video cookie compilation that I tried over last 1 year that I have started my paper. So these are hydro procedures beyond hydro dissection. So I will start with what Rajna ma'am was talking about, hypermature intumescent white cataract, and I created a baby Lexus with under viscoelastic, viscodispersive, then viscocohesive soft cell technique, and now I am using an irrigation cannula to wash off all the cortical fibers. This is only advisable when you suspect that there is no PPC. If you suspect or it has been earlier been diagnosed with a case of PSC or PPC, better to go with bimanual IA and decompress rather than going with an irrigation probe. Then you create a micro-recesses. This is all under OVD again, it's not under hydro, but surgeons have tried under hydro also. So enlarging under OVD. And now what happens when you clean everything and suddenly a small piece comes from behind the iris? One option is to create an IOL scaffold, but again you have to inject OVD and then clean it back. If you are trying for hydro implantation, the first thing you try is to crush it between your IA probe and then take it out. But this piece was of a hard brown nucleus, so it was not getting crushed. So what I did is press the lower lid and created a flow outside, so it came and stuck into the main wound. But again, it was not getting out with the aspiration cannula. So then I used McPherson forceps that is used for loading the IOL, and then I pulled it out. So coming to the third use case, that is hydropolishing the posterior capsule with irrigation probe. I think this is being commonly done with, from everybody. And rather than going with an aspiration probe that is having sand blasted, it's much safer to use your viscoaspiration. The trick is to direct your flow towards the base of the fiber so it gets loosened and then gets washed off. If you are just moving in the plane above it, then it won't budge. So you take your cannula and you aim at the base of the fiber and it will get washed off and you will get a nice shiny piece. So that is the routine hydro implantation of IOL that is being done, and the second haptic being done into the capsule. Now coming to the fourth use case, that is hydro polishing of anterior capsule. Just as in posterior capsule, anterior capsule can be also hydro polished or can be polished using the aspiration cannula under the BSS flow. The only side effect will be the patient can have dysprotoxia. If we leave that anterior rim with some fibers, it gets opacified and the dysprotoxia is less in those patients. But sometimes you just tend to clean because it doesn't look nice in recording. So that was the case I was recording, so I wanted to clean it. I am showing just the one half where I am cleaning it, the same way it was tried. The thing to notice is that when I am pulling the cortical fiber, it is not coming inside directly, radially, it is coming tangentially, so you loosen some surrounding fibers also. Now the next use case will be hydroimplantation in iris prolapse. Usually the hydroimplantation is contraindicated in the prolapsing iris. It is because when you press the lower lip, the iris will come out and create a damage. So how to do it in such cases? So first you go with an irrigation probe, then stop the flow and pull everything inside. So nothing is popping out from any of the side port or main one. Then you again go from a side port to stop the flow. Don't press the flow. You can see the ACS collapse, and then you start injecting your IOL, and then you start the flow. That's it. That much is needed. Bad luck, this IOL flipped. So again, then I have to do maneuvering. Under the hydro, it is possible to flip the IOL. It is not such. Again, same thing. You stop the flow so that it is not pushing it upside down, and then you tilt it, and it will nicely go inside. So after this, I thought why not to try hydroimplantation in SICS. If I can do with prolapsing iris in phaco. The same thing can be applied in SICS also. So I generally use bimanual irrigation aspiration to clean because I get more better cortical cleaning at a faster thing. So same process I applied. Then I stopped the flow, injected the 3-piece IOL. I usually use 3-piece IOL, don't use single-piece IOL in such cases. And then under the irrigation, I just dialed it inside. So here we have to take multiple because the multiple rotation, because it was not going into the bag, but again after 2 rotations it went into the bag and IOL was stable. So another use case that I found, luckily it was a case where I tried hydroexplantation of BX. I sadly couldn't record it. So second case I tried to record and suddenly it started spinning. It was not happening in first case. I was very happy, I was very confident, and suddenly in the second case it started spinning. So again, the trick is whenever you are getting something that is not going in your way, stop the irrigation, you will get. So I stopped the irrigation and then I pulled it out, started the irrigation, it worked. Second case I was so scared that I didn't leave the BX ring throughout the throughout the hydroexplantation, and you see it is very traumatic to the iris. It is very traumatic to the iris. I would not advise this way. You have to have it 2-step. You have to disengage it and then pull it out. In the third attempt, I got the trick, and since then I have not faced any problem in hydroexplantation of any of the BX ring. That is coming up right now. Sorry, the video is little blurry because I was tinkering with my camera settings. So here what I do is I take the micro forceps, that is a 5-voltic forceps. I take it out one flange. You can see the flange that is below the iris, below the irrigation probe. I catch it. I disengage 2 of the vertices. I catch hold of it. Half of the iris hook is, half of the BX is disengaged, and then I pull the vertex that is closest to the irrigation probe, the main one, and I pull it out. This PX hydroexplantation is done only in cases that it can be done in cases where I am doing hydroexplantation, because again injecting visco and taking it out again, if we are going to have toric IOL or something, it can create a problem. So that was okay of all the cases I could do in last 1 year.
Thank you, Dr. Nilesh. It's very nice to see that the youngsters who are coming in and coming back from training and setting up their new OTs are getting such good quality recording systems, because the more and more number of people record and present, it adds to the knowledge of everybody else. Thank you.
Next speaker is Dr. Taladun Fatima, who will be speaking on pediatric cataract management. She is a pediatric ophthalmologist of repute. She is practicing in Patna.
Good afternoon, everybody. Today I am here to discuss pediatric management of pediatric cataract. Cataract can be classified as congenital or acquired, and it has got a huge rate of morphological picture, and often surgical planning is based on the morphology. Acquired cases are mainly traumatic or spherical. Indication of surgery is size less than more than 3 mm, distorted retinoscopy reflex, vision less than 20/40, and if the child has got problems in the school. So here is a case showing that the child has lateral anterior polar cataract and he has got very good vision, 20/25. So in this case, there is no need for surgery. So the objective of surgery is twofold. First of all, to clear the visual axis by removal of cataract and focus retinal image by giving IOL or glasses. So what are the difficulties in these cases? Smaller eye, anterior capsule is more elastic, lower axillary rigidity, increased vitreous pressure, unstable anterior chamber, and problems in IOL power calculations. Surgery is technically demanding and post-op inflammation is very high. The younger the child, the more marked the differences are. We need a good infrastructure having a scan keratometer, handheld keratometer, so we can do keratometry under GA. in children less than 8 years can operate on biometry, and therefore eye power can be estimated prior to surgery. Formula found to be most predictable are the validated formula and the SRKT. The method of choice is optical biometry or immersion biometry if you are doing under EGA, and we have to undercorrect based on the Dahan's rules. A good setup is required with a good GA machine, and we need a very nice good cutter with a very high cut rate. And we also need these microsurgical instruments which are used to manipulate things in a small eye. Anesthesia in older age group can be given local, but cooperation can be judged by doing biometry and other procedures. Globe size is bigger as compared to our vital volume, so periverbal block in these cases has to be given very carefully. LN with sedation can also be done, and GA should be planned in certain cases. So always put an intracat even if you are operating an older kid, and nil oral preparation should be done in these cases, and a good GA backup should be there. Surgical steps like main incision can be scleral or limbal. Side ports can be given by side port plates or MVR. MVR is better than side port plates. The anterior capsular rexus is the most important. The manual CCC is still the gold standard, and the bull is towards the center as compared to adult cases. So here I am doing this rexus, and as you can see, the bull is towards the center, directed towards the center, and then it becomes very easy. The size of the CCC should be adequate. It should be at least 5.5 because contraction is also very common in these cases, and if it is large, then it will cause optic capture and uveitis. The advantages of manual CCC is that it has got good resistance, and there is lesser chances of eye decentration, and it is considered to be a gold standard. But the disadvantage is that it has got a long learning curve, and it is not possible in fibrosed capsule. Hydrodissection procedure can be done by using a thinner gauge cannula like 30 gauge, and it has to be done in multi-quadrant thing. If we see a lenticonus in these cases, we shouldn't do hydrodissection. Cataract removal can be manual using AC maintainer or automated. Here I am using the bimanual technique to remove the cataract. The cataract removal is easy because the cataracts are very soft, but the removal cortical clinic has to be done very meticulously, because even a small amount of cortex that remains is going to cause you a problem. It will cause severe uveitis in post-op period. So retroillumination while doing these cases is necessary. Sometimes you find this plaques, and we have got a tendency to cut it by a cutter. But when you see that if you try, you can also peel these plaques, especially in kids more than 8 years or 7 years, where we don't need to do a PCC, we try to cut and remove this plaque. So gently I am doing using the rexus forceps, doing gradual viscodesiccation, and at the end of the thing, the center is attached very adherent to the PC. So the last maneuver is like rotation part, and if you see while I am rotating this, it loosens off and comes up. PCC is the must in all pediatric cataract, I would say, because rapidly the vitreous gets opacified, the PC gets opacified. Even if you do a very good gap, then it doesn't clear off very nicely. So a good PCC doesn't have any replacement, and the technique is very simple, and it is very simple to anterior CCC. So sometimes when you see these cases, it is very common also. We see a large PC defect, and then you can see you have to do put the lens, and I can do vitrectomy after putting the lens also, because the PC is very delicate in these cases, and it can extend very rapidly. So here is another case of persistent fetal vasculature, in which we needing an endocarditis. So vitrectomy is a bimanual vitrectomy is better because it offers better chamber stability. Pneumatic cutters are always better than other cutters. Venturi pumps are better than peristaltic pumps, and we can also use triamcinolone 0.2 ml, 124 milligram per ml to use for better visualization. The choice of oil in this cases are hydrophobic acrylic lenses or multi-piece lenses if we are planning a secondary IOL. So what about multifocals? There are various studies coming up with multifocal lenses, but we are not, I wouldn't recommend it because for two things. Number one, do we get a spectacle independence? The eye is growing, so how can we get have got very good near vision because of pseudo accommodation. So I always advise monofocal lenses. Closure of all the suture wounds has to be done using a 10-0 vehicle in the modern area where you don't want to remove the sutures. Post-op care is very important. A team is needed to for a better post-op care support, and classes has to be given which should be executive bifocal or D-type bifocal. Regular follow-up and pressure monitoring is required. Pediatric cataract surgery is a teamwork consisting of counseling pre-op, intra-op, post-op. Specialized ocular surgery, it requires a vitrectomy, good cutter. It needs a GA backup and good post-op follow-up and care. However, it increases the life expectancy and it has got a positive psychosocial impact on the society. So at the end, I would like to end this talk by the common saying that intelligence and capability are not enough. There must also be a joy of doing something beautiful. Thank you.
Thank you, Dr. Tarado. Pediatric cataract is the most challenging cataract surgeries that we routinely do, and very rightly pointed out that every step of the cataract surgery, starting from the incision to the rexus, managing the nucleus and the cortex, and then finally the PCC, and then doing the anterior vitrectomy. Also the IOL power calculation, everything must be spot on for giving a good, clear visual access for the child who has to have that for the rest of his life. We cannot dilly-dally and say अच्छा ये कल सीख लेंगे तो कर लेंगे, वो नहीं हो सकता है. So thank you very much, and I think that's the end of our session.
Yes, I'd like to thank Dr. Shalab Sinha, Dr. Ranjana and Dr. Amitabh. I would now like to call Dr. Amarnath is here, Dr. Shakila Ansari, Dr. Manish Kard, please come on the chair, Dr. Gopal Prasad, okay, so can I request, where is Kunal? Okay, can I ask Dr. Pallavi Sinha? Dr. Pallavi, can you please join us in the chair, please? Dr. Gyan Bhaskar. Dr. Sanjeev Kumar is here. Dr. Ajay Bharadwaj. Dr. Vibhuti. So Dr. Gyan, please.
Good afternoon, everyone. Now we are going to start last session of today. May I request Dr. Nilesh Kumar, beginners, directly a small picture.
Thank you, sir. Thank you again for this opportunity. This is because I am a beginner in phaco surgery. It has been 2 years since I started and 1 year into my private practice. So I am just going to talk about what's in my armamentarium to manage small pupil treatment. So, a small disclaimer. What is small for me can be large for the experienced surgeons. So there can be some discrepancy. And the first step in all the small pupil is to inject Phenokin Plus. That is my go-to. That either Phenokin Plus or T Ultra. That gives quite decent size in most of the pupil. But if it doesn't enlarge with Phenokin Plus or T Ultra, then I inject a viscoelastic, and then again 10% of the cases I get decent enough viscodilatation. But coming to these kind of stuck pupil, what to do in such cases? Gently go with a irrigation cannula or a visco cannula with BSS inside and try to release all the thing. There has been discussion earlier that visco can be used, but I prefer to go with BSS because I have to stain. Then I go with the stain first. You can see I always go below the iris plane, go into the in that area, leave it for 10 to 20 seconds, and then again wash it off, so I get a good staining, and then I proceed with what I have to do. In this case, I tried stretch pupilloplasty because this is a ICS case and a black cataract. So I was not aiming for anything conservative. I stretch it from end to end, limbus to limbus, with 2 crutch retractors, and a decent sized pupil is formed, and I can then proceed with my regular surgery. Now coming to the next case, again a black cataract with white fibers. In this case, I decided to go with Irisoc. This is the only time I have used Irisoc actually, and I just wanted to record a case, so I used. Otherwise, this case also could have been done with stretching it a little bit. The only thing that is against Irisoc, it is a beautiful device. It gives a really good dilatation. The only problem is it takes time. This entire surgery went for 25 minutes, and 15 minutes of it was putting Irisoc inside. So the trick is to just place the Irisoc in position for all the Irisoc in position, and then start to tightening it and titrate whatever dilatation we need. We should not pull it with the iris to one side and then again struggle with putting the Irisoc in other ends. So I am using 4 Irisoc here. 5 Irisoc can be used if we need greater dilatation and more round dilatation. So this is how we did. Now coming to the next case, and this is my most favorite solution of a small pupil BH ring, because it gives us a complete regular round pupil after hydroexplantation, and patient doesn't even know that the iris has been manipulated with on next day. So this is a routine implantation of BH ring. That tip I got from Suven Bhattacharya sir, who invented this device, is to keep one vertex opposite to the main port, one vertex towards the main port, so you get 2 flanges on one side. So with one side port you can access 2 flanges, and with one side port you can use this, insert the 3rd flange inside, and you get a decent implantation. So this is a case where I got stuck. After I completed the rexis, the pupil became small. Now what to do in such cases? Again, Suven sir had taught me this. I went behind the iris, I injected the visco, so it is lifted off. In this case, you can see what I am doing is I am grasping the flange, I am putting it inside, and then I am slowly moving, I am pushing it away and rotating it. So in this way, I am sure that I am beyond the capsule, and capsule is not engaged into the BX ring, otherwise it can get torn. Similarly, I do for all the 2 flanges. 3rd flange I need, if I do, then this will disengage the BX, so I don't do that. And then I completed the case. But sometimes one is not enough. So again, same thing, I go below the iris plane, I inject, I wash the trypan glue, then I inject the viscoelastic. Now I thought that a 3.5 mm pupil is there, I'll put the BX ring and it will work. But then after engaging the 2 flange, when I tried for the 3rd flange, the third flange was not coming in, and there was a risk of iris dialysis from the other end. So now, in between, I stretched the pupil. I stretched the pupil, the other 2 flanges luckily stayed in place, and then I engaged the 3rd flange, and then as usual the case went on, and it was a good outcome. And now coming to the last part, less is more. Sometimes when you are confident enough that the pupil is a decent size, the nucleus is soft, better not to manipulate the iris. It is not always advisable. Sujit sir has done keyhole phaco in 2 to 3 mm, but for me 5 mm is decent enough. So whenever I am able to see the rexis margin that is decent enough, I don't do anything. I just perform a routine phaco, and similarly in this there is nothing great. Everything normal phaco is being done. So a routine cortical cleanup, and then the hydro implantation was done. But what is the aim of doing a phaco, all this, visualizing and doing all things, is that have you placed the lens in the bag or not? So always at the end of phaco surgery, where you have small pupil and you are not able to see the capsular margin, always use a wire retractor and see that you are in that plane. The bag, the IOL is in the bag. If it is not in the bag, you can do a manipulation. You can again keep it in the bag and then again recheck. So that's all from my side. Thank you.
डॉक्टर बाला का छूटा हुआ था वो अभी कर रहे हैं।
डॉक्टर बाला वीडियो
Is my voice audible?
Yes, yes.
So, next speaker is Dr. Shalabh Sinha, who will be presenting.
Shall I present my talk, sir?
Yes, Dr. Bala, please go ahead.
Yeah. Sorry for the technical glitches. And also trying to thank Dr. Manisha.
Setting, recording and progress.
The topic given to me was do's and don'ts in UVAs.
Can you make a slide full screen, please? The slides are not full screen. Yes.
Is slide visible there?
Yes, Dr. Bala.
So, the core concept of this presentation is to think the opposite, learn from the mistakes, avoid pitfalls. Like while driving in the car, the control of the brake is as important as the control of the accelerator. Yes. So, we all know that the skill set of the marathoner and sprinter are entirely different. So, similarly, in UV race, we have both long-acting and short-acting steroids. So the short-acting steroids, some of the long-acting ingredients may act as a mistake. Here we know that prednisone is going to be a short-acting steroid, whereas the Dexa is a long-acting. So giving long-acting steroid for long-acting PADs would be a correct treatment modality, whereas short-acting steroid for long-acting PADs can be a problem. So what can happen because of this is known to cause deactivation of UVAs. Actually, I did not appreciate this before I came across the presentation of American Academy of Ophthalmology. There they have mentioned this as a top one mistake in the treatment of UVAs. Similarly, the choice of cycloplegics can be a very difficult. Prolonged use of cycloplegics like atropine can cause posterior sanity in the dilated state. The best method of cyclolysis keep the iris mobile. A lot of ophthalmologists prefer to use cyclobentlate because the name cycloplegic they find the UV. However, cyclobentlate is known to break blood-ocular barrier and it is a chemotactic agent in neutrophils, paradoxically increases the inflammation. So we have to be very careful not to give cyclobentlate as a choice UV. The need of oral steroid is sometimes very important. Intermediate post-UVA is we cannot keep treating with topical steroid. This is a very ultra basic mistake that a lot of general ophthalmologists do. They start treating intermediate with 0 cells with topical steroids. And they even treat cystoid macular edema with topical steroid. And the only steroid that penetrates the intact posterior is benzcapitalide. The rest of the steroid topical steroid does not penetrate. The penny guide does not allow enough steroid to achieve the effective action for the lesion acting posterior pole. So we have to be very crystal clear on treating posterior VAs or intermediate VAs not with topical steroid but with oral steroids. The choice of giving steroid is also important. Good medical history is important. Infections, we have to be very careful not to bombard with a lot of local steroids, triamcinolone, intraocular injections can be potentially dangerous and can cause reactivation of toxoplasma or necrosis. So this is a very dangerous mistake not to give unless you are pretty sure there is a history of chickenpox or there is a history of toxoplasma. For all intermediate
steroids, the result is got infection. This is the third mistake not to do in treatment of uveitis. The fourth important mistake relating to uveitis is we should always be very clear that there are set of differentials for each of the agents. Some of the differentials are really challenging. Like in this case, vessels and acute electrolysis can meet each other, and one is a non-infectious infectious. For one, we will be giving a lot of steroids, immunosuppressives, but even to the extent of violence. However, for acute necrosis, even it's an infectious disease, we have to do specific infectious treatment. So be very, very careful in ruling out the differentials. Sometimes when we are not able to rule out the differentials, we go with the middle part. The next important do's and don'ts is treating pre and uveitis. A lot of us wish to undertreat children. We do not want to use a lot of oral steroids because cold retardation, we do not want to give immunosuppressants for children, and even biologists a lot of people think that it is little too much. However, certain uveitis like immunodeficiency arthritis or VLS sarcoidosis are treatable only with immunosuppressive and biological doctor legally described. So we have to be very, very careful. Have a threshold of tolerance for oral steroids and immunosuppressive as well. So the next important mistake is treating uveitis based on vision alone. For example, in epileptic uveitis, we cannot be thinking the vision is 6/6, we will not treat the inflammation. So you have vision as the only parameter, not the inflammatory indexes. Vision can reduce so soon, and systemic macular edema can take effect. So be very careful. In inflammation, vision is not the only parameter, we treat the inflammatory indexes. The next important mistake is we should be very, very crystal clear what is our definite treatment plan. For example, lens-induced uveitis, lens is also doing cataract surgery is a definite treatment plan. So don't wait for a period of poisons, whether you have hypervisual cataract, market, or lens-induced abscess. Don't wait for 3 months of poisons. Doing cataract surgery is a definite treatment plan. This is the pretty clear approach to do. So we should be very careful not to treat the test report. Sometimes PPD positivity or mantle test positivity is not equal to tuberculosis. You know that in Indian scenario, mantle test can be commonly positive. So don't believe only on a mantle test or any other test you order, serum ACE or whatever field based test. Whatever test you do, you be very clear that what are you going to do with the test is going to come positive, what are you going to do with the test is coming negative. So don't rely only on the test report and have a definitive treatment plan before you order. So next important thing we have to do is we should always be shameless to reconsider our diagnosis, and sometimes the rule of MRI is don't hesitate to repeat MRI. Similarly in images, we have to be very, very crystal clear when the scenario changes, when we have to repeat the investigations and we may order additional set of investigations. Because the early test has come out negative, don't be relying only on the test, because there could be reinfection or there could be another disease process acting concurrently. So this is the most important mistake I see in my practice. For anything and everything, people want to do this anti-PDM. We will be very crystal clear. Sometimes very hyperactive inflammation like severe pan-uveitis, Avastin can increase the inflammation and it's a relative factor. However, now even tubercular uveitis, a lot of our uveitis specialists started in anti-PDM, and that is a real exception. So for all pan-uveitis, don't start with anti-PDM, thinking that it will also start working. So Avastinophilia, we have to be very, very careful to avoid. So the next important mistake that the general ophthalmologist is whenever they want to give steroid cover for cataract surgery, they started giving IV steroids or local steroid and just do the cataract surgery. Steroid cover is not synonymous with steroid bombard. This is a wonderful article where they have compared IV steroid versus the overall steroid as a prophylaxis and concluded that there is a less breakdown of blood ocular barrier when you give oral steroid 15 days before followed with 15 days later after diagnosis. So steroid prophylaxis is not equal to steroid bombardment. Be very crystal clear whenever you are doing cataracts. So another important mistake is don't forget to do specific anti-inflammation therapy whenever we are doing cataract surgery. For example, in a toxic case with cataract surgery, or viral case with cataract surgery, or cancer sensitivity, having a singular CMV or CMVM, this inflammation can flare up and trouble us. People do not give a specific anti-inflammatory prophylaxis. So we have to think it out from the original disease process when we are treating the severe disease aspect. Another important common mistake is huge severities is one way it is the oral steroid is not going to help us. People keep on giving VAC steroid for huge phase of classification or topical steroid for that matter. And even cyclopens are not useful in huge severities. So huge is a sort of misnomer. So we have to be crystal clear. Not all these things PST or oral steroid or cyclopens for that matter. We are very, very crystal clear. Are we dealing with huge severities or not? So the next important mistake is uveitic activity in uveitic glaucoma are little challenging to handle because the inflammatory activity of uveitis can be independently graded by the uveitic expert and it depends on the intrinsic parameter. That means the grade of cell, the grade of vitreous scale or whatever the choroidal lesion. So any cell does not mean it is going to be active. So there can be even 2 plus cells with less activity that is going to reduce the dose of steroid and help the glaucoma. So we will very crystal clear to grade the inflammation independent of the grade of whatever condition you are going to see because the condition could be because of glaucoma as well. So grade the inflammation independent of the glaucoma. Never forget the sequelae. Sometimes we are very so close that we forget the site of the forest. So the vision loss of UV images can be because of the sequelae as well, like cystic macular edema, aluminum cyclic membrane. Of course, we all know cataract glaucoma. Don't forget to preserve the subtle sequelae like CME that are easily overlooked, especially when there are external scars. And the next important mistake I see among my residents is that treating intermediate is based, the correct method is to use the vitreous case and not the vitreous cells. So for all intermediates, I have currently identified that don't start with PST because injuries going of infection is very, very challenging. I had a patient who was initially given 4 series of peanuts. When he asked the test, the simplest test came out to be positive. And when he started the anti-syphilis treatment, I could see a very well healing necrotasis because the patient was already started with global steroid. The syphilis has gone for necrotizing rating. Normally syphilis is a necrotizing, non-necrotizing. When you start global steroid, you become a necrotizing. For intermediate images, don't first press the accelerator fully with local steroids. Of course, rule out the infection and not different treatment response when you are going to give a local steroids. And this is one test is commonly overlooked. For patients on oral steroid for more than a year, there is a risk for avascular necrosis of the female. Don't hesitate to order a bone marrow supplementary and make sure whenever the patient comes back to the clinic, the patient still walks to the clinic. Because if you forget to order this, the patient can even sue you and go for medical compensation as well. So you can just suggest them the test. I know that in places like in peripheral parts, this test may not be available, but however you can sensitize them this test. The drug-induced uveitis is commonly overlooked because you know that now everybody wants to go for artificial treatment. However, it's a poor replacement for medical history taking. There is a growing system called narrative scoring, and the highest scoring system is given for this person. So which can masquerade as a severe non-retinal actually the moment you stop the drug, the rate is going to stop. Instead, what people do is they start with high-dose steroid, immunosuppressant now, not only on the drug used in India. So meticulous testing is going to be a cornerstone in our current life. Rule of TV is a very important rule in Indian scenario because before starting immunosuppressive, definitely we all know we are going to When the patient comes for a follow-up also, we have to keep our mind open. We ask the patient is already close because there is risk for tuberculosis. And nowadays people started using biological research techniques until or even severe form of entities like AALs. We have to be very crystal clear. Every uses keep an eye open to rule out the risk for tuberculosis. Very important. And not last but not the least, you know that nowadays scale of alpha blockers, moderate issues are important. Intermediate thing is do not do MRI brain and do multiple sclerosis. If you start taking a blocker, there can be a risk of deamputation. Nowadays, newer disease like interferon-induced arthritis is getting recognized. So even interferon is also a biological, it's not free of side effects. Always rule out the cause. Thank you so much. Hope I covered the impressive changes in my decade of practice. Thank you so much. Is there any questions?
Hello. Thank you, Dr. S. Bala Murugan. Any questions for Dr. Bala?
When we are talking about interferons not being used anymore, so is it applicable to that used for OSSM as well? I want you to hear it.
He is not listening.
That's why you can speak.
So you were talking about interferon being blamed for multiple sclerosis as well. So is it applicable to topical use also that we are doing it for OSSM? We cannot listen. Can you hear us, Dr. Bala?
I'm not able to. Can you repeat the question? Can you please? Our voice is breaking. Now it is clear.
Yeah, just wanted to ask that the interferon use, is it applicable to the topical use in OSSM as well, since now it's being implicated into multiple sclerosis reactivation and else?
Yeah, topical interferon, to my understanding, there are no rules. However, for sarcoidosis, because some of the reports from the Germany and other Middle East countries, they started using interferons. That is a systemic interferon. There are no reports on topical causing similar problems. Hope I answered your question correctly.
Thank you, Dr. Bala.
Thank you, sir. Dr. Sheller will be presenting on sympathetic ophthalmitis following repeated VR surgery, and his second topic is long-standing chorioretinitis may be hiding above. We request him to continue with the two topics due to the arrangements issues.
Okay. So, to make things exciting and to wake you up, Dr. Ranjan Rai has organized a fastest hands first after the presentation of Dr. Shalab and Dr. Tarannum. The local organizing committee has graciously kept 7 gifts over here, very good gifts, and it was for taking out that lottery system which didn't happen. So we are going to play a music track, and whoever tells us first of which song it is will get the prize. One person, only one prize. But after Shalab and Tarannum has spoken.
Come on the stage and you have to recite the song. Okay.
Okay, so thank you, Dr. Satyajit, for giving me this opportunity. For presenting my topic. So this is a very interesting patient that I came across. So this is what he looked like at presentation. You can see this is the frontal picture of the right eye. You can see bullous oxidative detachment, and the patient when he came was BLPR in his right eye and NPL in his left eye. What you will notice is that there's a ring of pigments in the right eye, and the left eye has some sort of corneal scar, and it is an aphakic eye with a fully dilated pupil. So when I looked at this patient with such high IOP, and patient was already on oral steroids, the first thing that came to my mind is that am I dealing with a steroid-induced CSCR? So I promptly stopped his steroids and called him and gave him the Diamox and everything to bring his pressures down. That didn't help. So this patient actually had undergone a penetrating trauma. The collar repair and lensectomy plus vitrectomy plus endolaser was done, and there was a recurrence in the retinal detachment. So he underwent the fluid exchange and the endolaser, and then silicone oil was injected in his eye. And very soon, the patient also had an SOR. And when he came to me, he had developed bilateral exudative RD. So when the patient did not improve, then I changed my diagnosis and I gave him pulse steroid therapy. So following the pulse steroid therapy, you can see the right eye, almost the entire fundus, which was bullous detachment, has resolved. He has some amount of fluid subfoveally, and even the left eye from no PL became into a PLPR, and he has an epiretinal membrane in his left eye. Then the patient was started on oral azathioprine, and the patient continued to do well. You can see the resolution of the fluid, but of course he has that CME with the epiretinal membrane in his left eye. And over 1 year, what you can see is that the patient has gradually improved from PLPR to having a visual acuity of 680, best corrected visual acuity of 680, and the sympathizing eye, that was the right eye, has some the damage has been done to the retina and the choroid, but the patient is mobile. And this is the last visit. He came a few days back with a little drop in vision, and he said, and I attributed to the development of cataract in his right eye, but he definitely doesn't want a cataract surgery immediately. He's so afraid of surgery. So sympathetic ophthalmia is a rare and a devastating disease defined as bilateral uveitis following an eye injury or an eye surgery. It may result in permanent bilateral vision loss in an otherwise healthy patient with no ocular morbidities. And the symptoms and the timeline of the onset of symptoms and the injury are highly variable. And this is what we learn from history, is that it was first completely described by William Mackenzie in 1840, and the term, and it was, the histopathology was done by Ernest Fuchs. And there doesn't seem to be a decrease in the incidence in spite of using oral steroids. And as far as the etiology is concerned, that it may be that there is a delayed hypersensitivity, possibly directed at the surface membrane antigen, which is shared by the photoreceptors, the RPE, and the choroidal melanocytes. And the only effective therapy which was done in the past is the enucleation of the injured eye. So then I went to the literature and I tried to find whether there is any post-surgical sympathetic ophthalmia, because I wanted to know why the patient develops sympathetic ophthalmia. Is it the injury or is it the repeated VR surgeries? And yes, I did find a few articles, and it said that the vitrectomy and scleral buckling were the most common inciting surgeries that can result in sympathetic ophthalmia. And another article which said that the risk of increases if vitrectomy is accompanied by accidental penetrating trauma. So this is something I was totally unaware of. I never knew this. This was a large study that was done by Dr. Gas, and we all know Dr. Gas was a very reputed eye surgeon, did a lot of work on ocular inflammations. So that is the end of my presentation. I would like to ask Dr. Amita, what do you think? Is it the injury that has caused the sympathetic ophthalmia, or is it the repeated surgeries that has caused the sympathetic ophthalmia in this particular case?
I think it's difficult to decipher whether it was because of the initial insult or was it because of the surgery, because the presentation would remain the same. And there are reports of sympathetic ophthalmia developing from 5 days from surgery, that's the earliest that has been reported, to almost around 2 to 3 decades after the initial surgery. So time also is not a constant feature. So I don't really think we can actually figure out whether it was because of the injury or because of the time remaining.
What was the initial site of injury?
What was the?
Initial site of injury. Injury.
It's a corneoscleral tear.
Corneal. So you mean that ciliary body, that part might be injured because of that primary injury?
Maybe. The scleral involvement was very less. It was more corneal rather than scleral. That is why the surgeon who treated this patient took up for a combined surgery. Had it been a tear in the sclera also, it is difficult to do a vitrectomy in an open scleral wound, even if you stitch it.
Actually, not only open probe injuries, closed probe injuries can also cause sympathetic ophthalmia. And I have had patients who have developed SO after cyclophotocoagulation. I had a patient who just had blood trauma and a hyphema, and he developed sympathetic ophthalmia. So even very minor trauma can cause SO.
So even corneal ulcer can cause sympathetic ophthalmia. One case we have reported corneal ulcer after 15 years, patient developed sympathetic ophthalmia.
Okay.
Yeah, so the reason I brought this case for presentation is because generally we don't tend to see sympathetic ophthalmia in our clinics. It may have been more common in the past. Dr. Gupta may have seen many patients in the past, but I don't think abhi aap utna patient dekhte hoge sympathetic ophthalmia ka. So, but you have to have that thing at the back of your mind. I made incorrect diagnosis of steroid-induced CSCR, but actually it was sympathetic ophthalmia. So another interesting case, this lady, she is 36-year-old female diabetic patient. She was being treated at multiple centers over a period of 1 year for posterior uveitis. And then when she came to our clinic, she had a best-corrected visual acuity of 636. And as is usual, we don't really look into what the patient may have. She does improve, and that is what I also did. The only addition that I made was that maybe let me add trimethoprim and sulfamethoxazole along. And because she was a diabetic, I did want to give her Vicelone or prednisolone. I started her on deflazacort. And she came back after 2 weeks with PLPR in the left eye and 624 in the right eye. So suddenly I realized that I had made a mistake, and as has been told to us the whole day today, that you must be able to rule out infectious etiologies before you start oral steroids or your antimetabolites or whatever you want to give. So you can see in the left eye the large increase in the chorioretinitis and the amount of fluid that she has with some subretinal fibrin. So this is when I realized my mistake and started her on ATT. AKT4 was started for her. After 1 month, the vision started to improve in the left eye also, 660. The lesions in the choroid have started to heal. The fluid also has gone down. After 3 months, the patient is still improving, 618, 636, the fundus looks better. The disc hyperemia, however, is still there. And because the patient and her husband were wondering why I have started to look at TB का दवा क्यों दे रहे हैं डॉक्टर साहब, क्यों हम TB का दवा, इसको तो TB में कोई लक्षण ही नहीं है. So फिर भी I told them that no, she needs. So but then I tapered it from AKT 4 to AKT 2. She came back again with some drop in vision in her right eye, and that is when I decided to give her, you can see some cystoid matter developing in the right eye. I gave her posterior translobe. She is still on AKT, and then once she completed her AKT, you can see right eye still has some cystoid matter edema, and I've started on azathioprine. So I think this is a case that illustrates that this patient most probably, and I've written presumed tubercular chorioretinitis, is presumed because I didn't do a PCR and no chest high resolution CT of the thorax. Chest X-ray and Monto were negative for this lady, but the only thing that worked in this lady was the ATT, and that is why I think that this is a presumed tuberculous chorioretinitis. And this is what I learned from literature. And what we have also listened throughout the day, that we have to keep an infectious etiology always at the back of your mind whenever we are treating any post-uveitis patient, and this has already been repeatedly pointed out by almost all our guest speakers. Thank you.
Thank you, Dr. Sharad. Any questions? Now I invite Dr. Tarun Fatima with a presentation on pediatric uveitis approach and management. And this is the last presentation of the day and the session. But please stay back, as Dr. Ranjana has some surprise element for you all.
Good afternoon. Today I am here to discuss pediatric uveitis approach and management. Though childhood uveitis, pediatric uveitis is less common as compared to adults, it constitutes only 5 to 10% of all the uveitic cases. Still, it is since it is full of challenges, as thorough examination in children is very difficult. There are delays in diagnosis is very common in this case, and also there is very high ocular morbidity. The etiology can be idiopathic, non-infectious or infectious. In the various studies coming from India regarding pediatric uveitis, in South India they found out that toxoplasmosis was the most common infectious cause, and GIA was the most common non-infectious cause of pediatric uveitis. And studies from North India show that tuberculosis, GIA and toxoplasmosis to be the most common causes of pediatric uveitis. The most common cause of vision loss in pediatric anterior uveitis are cataract, band keratopathy, glaucoma, cystoid macular edema, and stimulus deprivation amblyopia. Severe vision loss is very high in these cases, and it is around 25 to 30% of the cases. The goal of treatment is twofold. First of all, to diagnose whether it is idiopathic, infectious, non-infectious or masquerades. And the primary goal of treatment is to suppress the active inflammation and also to decrease the risk of complications. If the cause of uveitis is infection, appropriate therapy for that infection should be employed with or without anti-inflammatory therapy. Non-infectious uveitis treatment is based on multidisciplinary approach between the pediatric rheumatologist and ophthalmologist is the key to successful treatment. So how do we manage these cases? The first line treatment is always a corticosteroid. Although diclofenac is the most potent topical corticosteroid, however, prednisolone acetate 1% is the most commonly used topical corticosteroid, and it has also been recommended by the American College of Rheumatology. Also, they have pointed out that stepping up the topical corticosteroid is better than giving systemic steroids, because systemic steroid should only be considered in cases of resistant, intermediate, posterior or paralytic cases, because it is associated with serious side effects, especially in children, because there can be growth retardation, weight gain, hyperglycemia, infection and osteoporosis. In GIA, uveitis occurs in 50% GIA patients who are female patients and positive ANA, and they are usually a negative rheumatoid factor. They are usually insidious bilateral non-rheumatous pyelonephritis and frequently associated with complications. Here is the case of GIA associated uveitis. Patient has got both eyes and anterior non-rheumatous uveitis with posterior signing in 360 degree with complicated cataract. So screening after diagnosis in the first 6 weeks of diagnosis, and which has to be continued up till the age of 12 years, is necessary in these cases. The steroid sparing drug also becomes very important in kids because we don't want to give systemic steroids, and methotrexate is one of the most commonly used drugs, and it has got a very good safety profile. Among the biologicals, they are the first line and the second line drug, and the Syncamol study shows that combining adalimumab with methotrexate can improve the outcome of the disease. However, must be noted that all these biologicals have to be given subcutaneous or IV, and so they are very poorly tolerated by kids. The surgical interventions are required when there is cataract, and when there is non-infectious CME, we have to give intravitreal steroids sometimes. And if they develop BSK, especially if it obscures the visual axis, and in glaucoma. Cataract surgery should only be done after 3 months of the question period has been reported. And hydrophobic acrylic lenses are the lens of choice, or heparin coated PMA can also be used. Silicone lenses should never be used in these cases because of the high risk of PCO and the highest rate of uveitis relapse. So here, during the surgery, taking out of the pupillary membrane is being done, and sometimes we can use this stretching technique, or we have to use this iris hooks and this rings. And sometimes, if we need to enlarge the pupil, we have to resort to making small sphincterotomy also. In cases of band keratopathy, we need to do chelation with EDTA. Since EDTA is not used for, is not present for eye use, so we can use this EDTA vials which are given to the, which are used by the pathologist to collect the blood. So each vial contains around 5 milligrams. So you can use 4 vials in 1 ml to constitute the EDTA and to get 2.2%. And here you can see this band keratopathy, and so we can use this well to apply this EDTA, and gradually we can scrape the deposits on the cornea. So this should especially be done when it obscures the visual optical axis, and then you can scrape it. So band keratopathy can also be managed by PTK, and the other is Ozurdex. It should be only given in cases of non-resolving CME. So often we are concerned for secondary rising IFP. So one thing that is important in these cases that those patients whose IFP doesn't rise much after topical steroid, the IFP won't rise even after Ozurdex injection. It is just given like any intravitreal injection, only you have to go a bit more obliquely and then inject it. Complications are hypotony, PCO, synechiae, retinal detachment and phthisis. Tuberculosis deserves a special mention because the tuberculosis is still very high in India, and the main diagnosis is mainly clinical, which is choroidal tuberculoma, optic occlusive retinal vasculitis and multifocal serpiginous choroiditis. It is based on history and CBC, and 2 classes of tests. The tuberculin skin test and the ICRA test are the main test recommended by the WHO. So tuberculosis diagnosis in the eye is mainly presumptive, and we have to start the treatment on this. There can be, this photograph shows a paradoxical increase in the size of the lesion when ATT was added on this after steroid, after giving steroid, but after giving ATT it resolved. So pediatric ocular toxoplasmosis is also very common in India. It can be acquired by congenital, which the classical lesion is right over there on the macula. And when it is active, it shows like a headlight in fog appearance. The management in antenatal, if it is diagnosed in the mother, in the first trimester, it is not, it is very detrimental for the kid, but if it is in the third trimester, then it is not so detrimental. In antenatal, we have to give spiramycin in the mother, and in the postnatal period, we have to give pyrimethamine, sulfamethazine, and glucoverin for 1 year at least. Which, in a nutshell, pediatric uveitis, although less common than in the adults, is associated with more complications and ocular morbidity. There is difficulty in diagnosis and late presentations are very common. A multidisciplinary approach with a good rapport between the ophthalmologist and the rheumatologist is required for successful management of these cases. Thank you.
Thank you for the nice and elaborate presentation.
Thank you, sir.
Thank you very much to all the panelists who are here. I'd like to call Dr. RAJGIR. Pallavi, you can do it. Come. Both of you can do it together.
So it's academics now. No. Just को allow नहीं है. Come. So there are 3 types of questions we can ask. One, we will play the song, you have to guess the movie name. Second, we can play the music, you have to guess the lyrics and you have to recite here. So which one you would like? Lyrics, okay, fine.
कंपटीशन से बाहर है
Yes.
तो आता ही नहीं है
आप लोग
खड़ा नहीं होना, ये लोग दिखेगा नहीं।
अरे हाथ उठाओ, चलो आओ।
अब पूरा गा के सुनाइए।
पूरा गा के सुनाओ।
लिरिक्स ही तो गाना है, वो निकाल लीजिएगा तो कैसे होगा?
ये तो होगा ना। ओ जाने जाना, ढूंढे मुझे दीवाना, सपनों में रोज आए, आज जिंदगी में आना सनम।
Okay, any better performer?
Okay, Salafina, first rank goes to you.
Thank you. अरे बोलो, इतना कॉमन है, अभी आओ।
आइए सर प्लीज।
हम केवल गाना का हेडलाइन बोल सकते हैं। आज बरसात की रात है कि लेने दो।
आ रही है आप लोग भी कर सकते हैं
सब लोग कर सकता है
जैसे की जरूरत है जैसे जिंदगी के लिए बस एक सनम चाहिए आशिकी के लिए बस एक सनम चाहिए आशिकी के लिए नेक्स्ट
इतना आसान है यार, मेरे को वहाँ बैठने दो।
एक घर में एक प्राइज जा सकता है, दो नहीं।
कौन सी बात है? इतने टैलेंटेड हो घर में तो प्राइज नहीं जा सकता।
यस आइए मैम, आइए कहाँ गए शकील बॉस?
आगे आगे बैठ जाओ, आगे आगे बैठ जाओ।
बारिश हो रही है, आप छाता तो लगाओ, छाता लगे आइए।
आप आगे
टिप टिप बरसा पानी ने आग लगाई, आग लगी दिल में तो दिल को तेरी याद आई, तेरी
Very nice. अरे इसमें छाता है, इसमें छाता है।
हेलो हेलो हेलो।
वाह, कॉन्ग्रेचुलेशन। कम 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 कम
एक बार एक प्राइज मिलेगा। देखो मेरा तो वो भी चांस छीन लिया है।
चलिए।
Movies हम साथ साथ है and the song is मारा के बड़ा में नाचे मोर तक तैया।
अच्छा गाने सुनाइए, फिर हम लोग क्रॉस चेक करेंगे।
खबरे ने मचाया शोर खिली दिल की कलियां बदला मौसम बदले नजारे या बदला है नजरिया।
Yes, is right.
बिल्कुल। चलिए प्राइज
ये
अभी भी चल रहा है। अब 3 गिफ्ट बचे हैं।
आगे बढ़ गया, चलिए इसके बाद बढ़ेगा।
बहुत आसान है।
Yes. Anyone?
भाई जज को मौका दो।
गुप्ता सर। अरे सारा प्राइज इधर जा रहा है भाई, इधर मेरे को जाना चाहिए ना।
आइए कोई।
पहले बता के जाते हैं क्वेश्चन।
ये कैसे होगा?
वो गलत है, जो तुम सोच रहे हो गलत है।
Everybody left for lunch. Everybody is at lunch. Lunch बंद करवाते हैं।
इतना
जज को प्राइज दीजिए तो मैं गा सकती हूँ। I don't know the question.
अभी भी नहीं, चलो।
चलो तो बताइए। एक दिन छोड़े हुए।
हाँ चलिए।
दिल है कि मानता नहीं ये बेकरारी क्यों हो रही है ये जानता ही नहीं हो दिल है कि मानता नहीं।
ये गाना हमारे यूजी डे का है। कभी हम भी हुआ करते थे।
ये 90s वालों का है।
नेक्स्ट।
मिल जाएगा। ये ऑनेस्टली ले रहे हैं क्योंकि मुझे नहीं पता है।
यस।
कंफ्यूज क्यों हो रही हो? हम लोग भी कंफ्यूज हो जाते हैं। याद आ रहा है? तुझे देखा तो ये जाना सनम प्यार होता है दीवाना सनम।
Very good.
प्राइस देखो लेट टूटने का फायदा है।
अब बचा है लास्ट प्राइज। लास्ट प्राइज सर आप ट्राई करिए।
सर ऐसे नहीं ले रहे हैं।
इसके बाद
ये जिसका लंबा
चलो जितने लोग जानते हो सब लोग आ जाओ स्टेज पर। आ जाओ सब एवरीवन। नहीं आपको मिलेगा, लेकिन जो लोग जानते हो
दीदी तेरा देवर दीवाना, हाय राम कुड़ियों को डाले दाना।
सब सिंगर है
हाय राम कुड़ियों को डाले दाना।
वेरी गुड वेरी गुड। देखो देर आज होता है, इतने देर से हम खा ली थी ना।
चलो चलो
ये गाना गाएंगे, ये गाना कोई लास्ट चलते चलते कुछ मस्ती वाला
2 मिनट We have to do a valedictory function. I would like to call our President Dr. K.S. Gupta sir. I would like to call the Senior Most Officer Masjid Dr. Devendra sir. I would like to request.
Oh yeah.
Dr. Ajay, please come on. Dr. Arvind sir, please. So I'd like to start this valedictory. Please sit down. I'd like to request our President to begin with by thanking the LOC for all the arrangements that we made. Dr. K.S. Gupta sir.
ये मिडटर्म कॉन्फ्रेंस जो हुआ इसको हटा दो। ये जो मिडटर्म कॉन्फ्रेंस हुआ ये एक अनूठा प्रयोग हुआ और साइंटिफिक एक्टिविटी के अलावा डॉक्टर अरविंद कुमार जी ने फैमिली गेट टुगेदर करवाया। हम लोग हमेशा अपने साइंटिफिक एक्टिविटी में केवल मेंबर्स को इनवाइट करते हैं, अपने स्पाउस को भूल जाते हैं और जो जाती भी हैं तो उनके लिए वो छोटा मोटा रहता है टूर प्रोग्राम, लेकिन वास्तविक गेट टुगेदर जो एक दूसरे की वाइफ को जाने, एक दूसरे की स्पाउस को जाने, उनसे पहचाने और दोस्ती हो, वो कभी नहीं होता है। इन्होंने एक बहुत ही इनोवेटिव आइडिया लाया और इस आइडिया के लिए मैं इनका तहे दिल से धन्यवाद देता हूँ और बधाई देता हूँ और शाबाशी देता हूँ कि इन्होंने ऐसा किया। ये इस एमटीसी में 4 चांद लगाते। इस एमटीसी में हम लोगों ने कैटरेक्ट और यूरिया के लिए बहुत सारे वक्ताओं को सुना और हमारे ज्ञानवर्धन भी हुआ और ये उम्मीद से ज़्यादा पार्टिसिपेशन भी हुआ। इसके लिए मैं सभी डेलीगेट्स को धन्यवाद करता हूँ। थैंक यू।
Thank you, sir. Our Secretary and Treasurer has some urgent work, so they have left. On their behalf, I would like to request Dr. Gyan Maskar to please say 2 words for the local organizing committee.
Thank you so much, sir. अभी जो हम लोग देख रहे हैं कि प्रोग्राम खत्म होने वाला है और इतने लोग बचे हैं, यह सिद्ध करता है कि अरविंद सर, उनकी टीम, अजय सर, हमारे चेयरमैन साइंटिफिक कमेटी सत्यजीत सर, हमारे बॉस के प्रेसिडेंट के.एस. गुप्ता सर एंड जितने भी सीनियर फैकल्टी मेंबर हैं कितना मेहनत किए हैं। अदरवाइज लास्ट में ऐसा होता था कि जिनको प्रेजेंट करना रहता था वो रहते थे और 1-2 चेयरपर्सन रहे लास्ट में वही बचते थे। तो सर आप सभी को कि सर हम एज ए मेंबर साइंटिफिक कमेटी और आप सभी के तरफ से सर एक बार हम चाहते हैं कि आप लोग जोर से ताली बजाएं सर हमारे लोगों मर्दानी कमेटी के लिए। और एक रियल मेमोरेबल इवेंट कल भी था आज भी है और शायद जब भी राजगीर और नवादा और बिहार शरीफ को मिलेगा तो शायद हम लोग यही अनुभव करेंगे। थैंक यू सो मच सर।
Thank you so much. I'd like to request Member Scientific Committee Dr. RAJGIR to say 2 words, please.
नालंदा ऑप्थेल्मोलॉजिकल सोसाइटी और आप सबको तहे दिल से आभार। आप सबने इतने अच्छे से शिद्दत से हम लोगों का ख्याल रखा। वाकई एक यादगार कॉन्फ्रेंस रहा। उम्मीद करते हैं कि आप लोग पुनः हमें बुलाएंगे और हम आएंगे। इस उम्मीद के साथ आप सबको जो लास्ट तक बैठे हुए हैं उन सबको हार्दिक धन्यवाद। थैंक यू।
I'd like to request our senior most ophthalmologist Dr. Devendra sir to please say 2 words.
धन्यवाद। आप लोग बड़ी संख्या में यहाँ आ करके रात में भी इतना एंजॉय किए और ये साइंटिफिक सेशन चला अच्छा लगता है और इन्हें बार इधर आना चाहिए।
Thank you so much. Before we move on to the last 2 speakers who are representing the LOC, on behalf of Bihar Ophthalmic Society, I want to recount all the days of hard work that have been gone in by Dr. Arvind and Dr. Ajay. एकदम घर में जैसे बेटी का शादी के लिए लोग लगे रहते हैं वैसे डॉक्टर अरविंद जो है एंड आई कैन वाउच फॉर दैट और एंड डॉक्टर अजय और उनका पूरा टीम इतनी मेहनत और इतनी शिद्दत से लगे हुए थे कि ये प्रोग्राम सक्सेसफुल होना ही था और बहुत बढ़िया सक्सेस हुआ और इसकी चर्चा चारों तरफ हो रही है। बहुत बहुत धन्यवाद आप लोग दोनों आदमी को और आपकी पूरी टीम को बिहार ऑप्थेल्मिक सोसाइटी की तरफ से। ये बहुत ही एक अच्छा मैसेज गया और कल पहली बार सबको बोला कि बिहार ऑप्थेल्मिक सोसाइटी का एंटरटेनमेंट प्रोग्राम सबसे बढ़िया हुआ है कल रात में सालों में। एंटरटेनमेंट प्रोग्राम हर बार होता था लेकिन कल रात वाला सबसे बढ़िया हुआ है और इसके लिए डॉक्टर अरविंद एकदम शुरू से ही रहते कि मैथिली ठाकुर जी को बुलाना है और बहुत ही अच्छा कार्यक्रम रहा। खाना तो बहुत ही अच्छा था। पिछले बार भी 4-5 साल पहले यहाँ पर कॉन्फ्रेंस हुआ था, सब याद रखे थे। खाना इस बार भी बहुत बढ़िया था, पूरा वैरायटी था, सब कुछ था। एक चीज मैं भगवान को भी धन्यवाद देना चाहूँगा कि चारों तरफ भारत में पानी और कहर हुआ है और मुझे बहुत चिंता थी कि खाने का क्या होगा। खाने के समय अगर पानी पड़ने लगा तो वो एरिया खुला हुआ था लेकिन ऊपर वाले की कृपा से उस समय वहाँ पानी नहीं पड़ा। बिहार ऑप्थेल्मिक सोसाइटी की तरफ से हम आपको ऑडियो विजुअल की पूरे टीम को लास्ट टाइम हम लोगों को पटना में काफी दिक्कत हुआ था, कोई दूसरे लोग थे, बार ऑन ऑफ हो रहा था। आप लोगों ने इतना स्मूथली किया, हरी जी और उनके टीम बहुत बहुत धन्यवाद। और यहाँ पर इंडो के होटल के जितने लोगों ने मेहनत किया हम लोगों को खिलाने पिलाने में 2 दिन हम लोगों को ठहराने में, उसके लिए बहुत बहुत धन्यवाद। और अब मैं बुलाना चाहूँगा पहले डॉक्टर अजय को और तब से डॉक्टर अरविंद को क्लोजिंग रिमार्क्स देने के।
थैंक यू सत्यजीत सर। काफ़ी लेट हो चुकी है, फिर भी लोग हॉल में मौजूद हैं। ये परिचायक है कि हम लोग का ये कॉन्फ्रेंस मिड टर्म ही सही लेकिन इट वॉज अ ग्रैंड सक्सेस एंड आप लोग के गाइडेंस में ये संभव हो चुका है। हम लोग तो काम करते हैं लेकिन जब तक ऊपर से गाइडेंस नहीं मिलता कि हम लोग ये करने जा रहे हैं, साइंटिफिक प्रोग्राम किस समय शुरू होगी, ये लोग आएंगे, तो शायद हम लोग प्लानिंग उस तरह नहीं कर पाते। तो आप लोग का गाइडेंस रहा जिसके वजह से ये एमटीसी जो इतना अच्छा रहा। तो मैं बॉस को बहुत धन्यवाद दूंगा कि जिन्होंने हम लोगों को गाइड किया और बढ़िया से हम लोग कर पाए। थैंक यू।
At the end, I would like to call Dr. Arvind sir, who was the architect of the entire program.
कहने का तो बहुत कुछ है लेकिन हमको लगता है कि सब लोग अनुभव किए इस चीज़ को
और 2 दिनों से जो लगातार इंटरेक्शन, कल्चर प्रोग्राम, साइंटिफिक सेशन जिस तरह से हो रहा है, जो यहाँ पर जो सबसे पहले दिया गया था, मिड टर्म दिया गया था, तो हम लोग ने सोचा कि मिड टर्म तो और बहुत सारे छोटे छोटे टाउन्स में होते हैं, अलग अलग जगह होते हैं, लेकिन हम लोग को नालंदा डिस्ट्रिक्ट को नालंदा दिया है, और नालंदा में राजगीर है। राजगीर में इससे इतने सारे स्पॉट्स हैं कि हमको लगा कि यहाँ अभी फैमिली लोगों को आना चाहिए। और कॉन्फ्रेंस में हम लोग जाते हैं तो एक दूसरा के कल्चर प्रोग्राम में रात में फॉर्मेलिटी होता है, दिन भर के थका मांदा हुआ लोग कल्चर प्रोग्राम में फॉर्मेलिटी हो गया, खाना खाया चला गया। तो यहाँ से एक दिन पहले लोगों को रुकने का यहाँ पर जो हम लोगों ने एक प्रस्ताव रखा, और इसको आप लोगों ने सब लोग स्वीकार किया। आप लोगों के यहाँ स्टे करने के वजह से रात में उतना अच्छा गैदरिंग और किसी को हड़बड़ी नहीं कहीं जाने का, और इतना आनंद भी है। और हमारे शहर के जिनको कि हम 45 मेंबर्स को जो हमारे शहर में लाइक करते हैं लोगों से मिलना जुलना एक सोसाइटी में, में कैसे तो हमारे यहाँ 350 हैं, लेकिन जिनों को भी 45 मेंबर्स को बुलाए, और एक थोड़ा सा उनसे हम लोग का हक बनता है कि 5000 का कंट्रीब्यूशन भी उन्होंने से हम लोग लिए। उसके वजह से हम लोग बहुत सारा एक्टिविटी भी कर पाए हैं। और सबसे 2-3 बात है, 3 दिन पहले हम लोग जब जितना LOC के मेंबर 9 मेंबर हैं, हम लोग सब लोग जमा हुए थे कि हम लोग कभी यहाँ जाते थे, मीटिंग करते थे, हर अल्टरनेट मीटिंग करते थे। पटना में जितने भी लोग एक्टिव हैं सब लोगों से सलाह लेते थे। तो हमारे एक मेंबर ने, जूनियर मेंबर ने पूछा कि इतना दिन जो हम लोग मिल रहे हैं उसमें क्या विशेषता क्या है। सब लोग अटक गए कि क्या विशेष बात है ऐसे। तो उन्होंने कहा कि जो 9 लोग काम हम लोग कर रहे हैं, कोई कंट्रोवर्सी नहीं है, और कभी ऐसा हुआ नहीं कि हम लोग जो 9 स्टेट हैं यहाँ पर बिहार स्टेट में इतने प्रेम पूर्वक जो भी किया गया, जो दायित्व दिया गया, उसको हम लोग इतने ढंग से जो मिल रहे हैं, एक मिड टर्म एक बहाना है, लेकिन हम लोग ऐसे मिल रहे हैं। आज तक इतने बार कोई 20 साल से, कोई 30 साल से शहर में इस तरह से लगातार हम लोग 10 दिनों तक हर डेट में मिलते नहीं रहे। ये हम लोग के लिए खास करके नालंदा ऑर्थोडॉक्स सोसाइटी का एक उपलब्धि है कि हम लोग का रिलेशन बहुत ही स्ट्रॉन्ग हुआ है। और हम लोग कभी भी जिम्मेवारी दिया जाएगा तो जब सब लोग इतने मन से तैयार होते हैं करने के लिए, तो हमको नहीं लगता है कि कहीं कोई दिक्कत होगा। और सबसे बड़ी बात कि नालंदा ऑर्थोडॉक्स सोसाइटी हम लोग 9 लोग के कारण केवल जो फर्मा वाले हैं लोग इतना बढ़ चढ़ करके स्पॉन्सरशिप किए नहीं। पटना से भी तीनों को भी हम लोग ने कहा कि आपका जो जिनका स्पेसिफिक कुछ आपका कंट्रीब्यूशन है, जो अप्लाई आपसे हैं, सब लोग सहयोग कीजिए। तो सब लोग ने सहयोग किया, और हम समझते हैं कि इतना सब कुछ करने के बाद भी बहुत ही अलग, जैसे मेहंदी का व्यवस्था किया, अलग अलग ढंग से अपना कल्चरल एक्टिविटी अच्छा से ही, और खास करके वाटर प्रूफिंग के लिए वर्षा का जो उम्मीद था, बगल में हमारा कन्वेंशन हॉल है, लगा कि वहाँ पर हम लोग करेंगे, यहाँ पर लोग ठहरेंगे, थोड़ा सा आने जाने में तुरंत गाड़ी चाहिए ऐसे। तो हम लोग ने यहाँ जो वाटर प्रूफिंग किया, तो उसके कारण हम लोगों को दुगना खर्च हुआ, लेकिन लोगों का सहयोग आप लोग का रहा कि हम समझते हैं कि इतना खर्च के बाद भी हम लोग कुछ सोसाइटी को दे ही पाएंगे, पॉजिटिव भी आएगा। तो दूसरा चीज़ कभी भी हम लोग को लगेगा, इस काबिल समझा जाएगा कि हम लोग कॉन्फ्रेंस के लिए कहा जाएगा, लेकिन उसके पीछे आप लोग का सहयोग रहेगा, उत्साह रहेगा। तो हम समझते हैं कि राजगीर ऐसा जगह है कि पूरे स्टेट में आप नज़र घुमा, पटना में अगर लोग बोले कि वहाँ जाकर के स्टे कीजिए सब लोग, और एक दिन स्टे कीजिए या कुछ इस तरह का प्रोग्राम करें, तो लोग स्टे करेंगे नहीं, क्योंकि पटना से लोगों का ऐसा है कि किन्हीं का रिलेटिव इधर उधर। राजगीर ही एक जगह है पूरे स्टेट में जहाँ पर कि इस तरह का एक्टिविटी हो सकता है, और हमारे यहाँ फैसिलिटी भी बहुत है, और देखने के लिए भी जो लोग भी एक दिन में घूमे, हम समझते हैं कि मुश्किल से 1/4 जगह भी जो देखने लायक है उसको लोग देख नहीं पाए हैं। तो बाकी जगह देखने आने का मन होगा, कॉन्फ्रेंस के बहाने आप लोग अपना सहयोग करते रहिएगा, उत्साह बढ़ाते रहिएगा। हम लोग अक्सर इस तरह का जब भी होगा तो जिम्मेवारी लेकर के अच्छे से करेंगे। धन्यवाद।
थैंक यू सो मच। एक बार फिर से बिहार ऑफ हेल्थ सोसाइटी की तरफ से सब फार्मा कंपनीज को, NRI को और हमारे सब गोल स्पॉन्सर्स को बहुत बहुत धन्यवाद जो लोग हमारे प्रोग्राम को स्पॉन्सर किए हैं। So that brings us to the end of the program. Can we have the national anthem on?
Thank you very much.